Yeah, no worries.
And can you tell us when we're live? That'd be great.
And we are live.
Bore da, croeso i'r gyfarfod bod iechyd Brifysgol Cymraeg Morgannwg, Hofn yr Estyn, croes cynnes i bawb sy'n gwylio heddiw. Thank you, good morning, and welcome to the bi-monthly meeting of the Cymraeg Morgannwg University Health Board, which is being held in public. Apologies for the late start this morning. We are broadcasting today's meeting live, so a very warm welcome to all those who may be observing today's meeting. And of course, a copy of the video of the meeting will be available following today's board on our website for those who wish to view it. We have a large agenda today. Just to remind colleagues that many of the reports will have been to our committees this morning, and I would ask presenters to be as brief as they can in presenting the reports to board. We'll take a short break, probably around 11:45, just for the information. Can I welcome this morning to our board Dr. Michelle Smalley, consultant clinical psychologist. Michelle's here to share the listening and learning story, which relates to the critical care psychology service. A very warm welcome to Michelle this morning. Good to see you. Also, a very warm welcome to Kath Palmer, our new Vice Chair, who is attending her first public board meeting today, and also to Helen Lentle, who has been appointed as our new independent member legal, who is attending the meeting as an observer, but is also joining the board formally in January next year. It sounds like a long way away, but it's not that long away. Also, a very warm welcome to Suzanne Rogers, our Assistant Director for Digital Transformation, who is here on behalf of Stuart Morris. Just say Carolyn has joined us remotely, and can I also say a very warm welcome to Emma, who is joining us. And a couple of other items before we start with our shared listening and learning story. A huge congratulations to Philip Daniels, our new substantive Executive Director of Public Health. Philip, of course, was interim director for the past 6 or 7 months, but has now been appointed into the substantive role. So very huge congratulations from all of us, Philip. We have had apologies from Stuart Morris, our Director of Digital, Lisa Curtis-Jones, our Associate Member, and just to point out, Rosie Cavill, our Programme Director for the Campus and Health Park, is joining us in preparation for item 7.2. Item 1.2, apologies for absence, have been covered. 1.3, declarations of interest. Anybody has anything to declare in respect of the agenda which they've not notified me of? No? Okay, splendid. Right, item 2, consent agenda business. Just to, again, explain to colleagues and those observing the meeting, we do have a large number of items for consent that are put on the agenda that can be brought forward for substantive discussion. Nobody has asked for anything on the consent agenda to be brought forward this morning. And can I just check that's still the case, and that there's nothing on the consent agenda that people need to bring for more substantive discussion? No? Okay, thank you very much. We'll deal with those items towards the end of the agenda. We'll move on to item 3.1, our listening and learning story. And I'll invite Michelle to take the floor. Thank you very much indeed.
Thank you, and thank you for inviting me today to tell you what we've been doing in the critical care psychology service for the last few years. Now, I could talk to you for hours, but I have been told to be brief, so I have produced an executive summary. I don't think I've quite got enough copies. So if you want to have a deeper dive into the bigger picture, then please feel free at your own leisure. Okay, next slide, please. So I want to start really on the next slide, please. Sorry. Thank you. Why do we need a psychology team in ITU? Well, there are many sources of trauma. I'm not going to read all these, you can have a look at some of these, but for the patients, the relatives and the staff who work in ITU, I saw myself hemorrhaging. I might never wake up if they tube me, but I will die if they don't. My son survived, but I'm having flashbacks seeing him in ICU. I tubed that mum of 2 young children, knowing she'd never wake up again. When we withdraw care on a patient, I feel it is me personally pulling the plug. I feel sick. Some of these stories may be familiar to us, but what have we been doing about them? As professionals, as teams, we just push them down. We carry on regardless. But actually what intensive care medicine is telling us to do is to think not just about how many people we save the lives of, but the quality of the lives we save. We also need to shine a spotlight on what we already knew in terms of staff burnout and stress, and the COVID pandemic actually helped us to do that. Next slide, please. Thank you. So I started on the 6th of January 2020 on 2.5 days a week just to look at the Old Tap area and provide a psychological service to outpatients, or reactive service. We know that about 50% of patients who leave the hospital and have been through critical care end up with significant psychological consequences due to their stay in ICU. That could be post-traumatic stress disorder, anxiety, depression, suicidality, and memory problems, very similar to Alzheimer's or a head injury type presentation. So doing the maths, doing very quick maths, that's working out at over 300 patients a year from the Old Tap region alone, leaving with these significant problems. So we know that just providing a reactive outpatient only service, it'll get flooded very, very quickly. And indeed it did. We developed a 3-month waiting list within 10 weeks of me starting in the service. So what we also know is that preventative medicine is where we should be looking at this. If we can prevent this harm, minimise the trauma, get in at the early end of the care pathway, that's where we're going to make the biggest difference. But patient-centred care isn't just about the person in the bed and their values, it's the system they come with and they're cared within. So it's looking at the family, it's looking at the staff who care for our patients. If we address their well-being, their needs, we will also improve patient flow, reducing the number of days on intensive care and in hospital in general, but also work together as a team and therefore more effective healthcare. So the literature tells us that our families who have a loved one in intensive care, 1/3 of them will also develop PTSD, anxiety, depression, just from seeing their loved one in intensive care. And for those who lose a loved one in intensive care, half of them will go on to develop prolonged grief disorder. That's very different to typical grief. It destroys relationships, people can't function, they don't go back to work. PTSD, whether it be in our patients or our families, has significant ongoing consequences if it's left untreated. We have increased readmissions to hospital because of injury, illness, substance misuse, self-harm. People in that length of stress, it affects the physiological system. So your cardiovascular system starts to take a hit. So it's not just about the psychological system, it's a physical system as well. Okay. Prior to the pandemic, the literature tells us that any staff who work in frontline services, so that be ED as well as ICU, 1/3 of them are at high risk of burnout. At any given time in ITU, about 8% of staff have PTSD and trauma just from what they're seeing and doing on a daily basis. And the cost to the NHS is significant. So it's being calculated that approximately £2,000 per year per member of staff is lost to staff sickness directly related to mental health problems from work. So we know that we need to be holistic. We know we need to look into that. The pandemic actually helped me out because the outpatients got cancelled. So I couldn't deliver the part of the service I've been commissioned to do. So we turned our focus to family support and the staff. So we developed a family support service to bridge the gap between ITU and home. The whole world was in lockdown. Relatives were isolated. They were more suicidal. They had a loved one in intensive care. They couldn't be by their bedside, let alone hold their hand if they were dying. Our staff were facilitating death by FaceTime on an iPad screen. Now that's traumatic, whichever end of that screen you are on. Our staff were asked to risk their lives and risk their families' lives. And the families were isolated and terrified. After the first wave of COVID, 40% of our ICU staff had PTSD. They were treated through our psychology service, and within 3 months, they were back and ready, back on the workplace for the second surge. So outpatient clinics resumed, and we got a 400% increase in outpatient referrals because the trauma happening inside ITU was much more significant because the patients were sicker, they had more delirium, they were terrified of this global pandemic that had affected them personally. So in 2021, we put in a business case, which was successful, thank you, and we were funded to develop the service bigger. We weren't covering Bridgend at the time, so we were able to triplicate the service to the Bridgend ICU patients, staff and relatives, and we were able to continue to deliver the end-to-end care pathway. We developed an 18-month outpatient waiting list by this point with me on my own. So if we could just go on to the next slide, please. It took me a year because of recruitment issues to actually get this team in place, as it often does, sadly. So in actual fact, the stats I'm about to show you are actually outside of the pandemic. We're busier than ever, and we're actually working outside the pandemic. So the top line here is our inpatient contacts, and the bottom line here is our outpatient contacts. So once we've got our team in place, you can see the significant change in where these referrals went. We now make 500 inpatient contacts every single year across all 3 sites. Within 72 hours of a patient waking up on ITU, our team is in there assessing them for psychological risk. Those at risk then get an individual psychological care plan that follows them through the hospital, onto the wards and out to outpatients. As a result, instead of having 50% morbidity, we've got 10% morbidity. And we've done that in the last 2, well, not quite 2 years, 18 months. We've significantly reduced the trauma coming out the other end. As a result of reducing those referrals, we've gone down back to a 3-month waiting list, and it's been very static at about a 3-month waiting list. We can now expand to offer outpatient services to relatives. We can offer to do that to the staff as well. So if I could have the next slide, please. Thank you. So again here, so this is our family support service. So we've continued. The feedback from the relatives was overwhelmingly positive, that they wanted it to continue. They wished they'd had it, had they had a loved one in ITU years prior to the pandemic. We make 300 contacts per year to relatives and families. All families who lose a loved one in ITU now get offered a bereavement clinic with myself, one of the intensivists, about 3 months after we've lost a loved one, trying to address those holes in their knowledge, looking at the prolonged grief pathway and trajectory. We offer, as I said, outpatient service now to relatives who are presenting with PTSD because they weren't going anywhere. We don't know where they went. And the green line is staff. We're seeing about 75 staff a year. Now that's a combination between debriefs. We can offer critical instant debriefs when a bad, challenging, traumatic incident happens, but it's also one-to-one psychological care. Again, we're getting staff back to work faster than they would do if they were waiting for GP referrals, etc., to primary care. We're doing teaching, we're doing training, we're consulting, we're talking with the leads of the 3 ICUs to make sure that their pathways and their policies are trauma informed. So the reduction we've seen in outpatient morbidity isn't just because we're doing that inpatient at that front end, it's because we're looking at the service holistically. We have lowered patient trauma, we have lowered relatives trauma, and we have lowered staff trauma, stress and burnout. And we will be fast becoming the flagship service in Wales. We are the only critical care service in Wales that has an end-to-end psychology care pathway and is producing data like this. We've got our colleagues from across the bridge in England coming to us for our service model. We've done a really good job so far with the investment we've had, although the caveat is 60% of our funding is very precariously based on charitable sources at the moment. I'm going to hand over now to our patient story to really tell you the next bit of the story from their point of view.
Thanks, Michelle.
I hope it works. I have a YouTube address and I'll make you all put it into your phones if it won't work.
The guys outside got that YouTube address as well.
It's on my next slide actually.
But Carl and Carl, is it worth just following the YouTube link that Michelle's shared with you?
It's on the next slide on my presentation. I'll put it there just in case we have technical difficulties.
Very well.
Yeah.
No sound. No sound. No sound.
No. Which is
Laptops.
January 21, I was taken into hospital with COVID. I was then admitted pretty much within a week into intensive care, where I spent 31 days on the ventilator. Overall, I spent just under 4 months in hospital. After the stay in intensive care, I had to go and have extensive rehabilitation, learn to walk, talk, eat, drink, literally do everything again. So I couldn't do a thing for myself.
Well, I pretty much moved in with mum. Me and my sister took it in turns. I'd stay 4 nights for obviously 4 days. I was there every day. We'd have one phone call a day for an update on how Dad was doing. So it'd be our whole day was based around that one phone call from a doctor or a nurse to how Dad was doing. So yeah, it was tough.
Once I was discharged to home, my bed was downstairs because I still couldn't get up the stairs or anything. And my fears of meeting people or going outdoors, I just couldn't do it because I was too scared of catching anything, let alone COVID again, which could obviously put me back into hospital and who knows what could have happened. But yeah, I think that's the biggest thing is going out. So I just couldn't go anywhere.
Yeah, so we used to wear face masks, pennies. We wouldn't go anywhere near Dad. Everything was outside. So we'd sit on out to the garden. Dad would sit by the French door, so he didn't go outside. So yeah, it was tough for months. We did that. Wouldn't give him a hug, wouldn't give him a kiss, wouldn't sit this close to him. Constant face mask, penny, had to back our hands constantly. We'd wipe everything. We've got dogs, so we'd wipe their harnesses down before they even went near Dad. Yeah, it was very, very intense because he was so conscious of making sure everything was clean, as clean as possible.
And then prior to that, we were always a very close family. Always
Yeah,
at the house.
Yeah.
Okay. Do you want to take 5?
Yeah.
Yeah.
After being at home for a while, we had an invite, myself and my wife, to the intensive care survivors coffee mornings, where you had a chance to meet up with other survivors who've been through the same as you and talk about your experiences together. And it's whilst at these coffee mornings that I met up with Michelle, and she noticed I was still struggling with certain issues, which then we went on to having a face-to-face consultations to help me through my struggling issues that I was ongoing having.
Yeah, I'm very pleased. Obviously, the coffee mornings are a big step for Dad anyway. Getting out, being with people, being in a room with other people was a massive step anyway. So yeah, I know it was straight away that just the mornings were a massive help. So then obviously having his individual appointments with Michelle were even more helpful, which is, I think that's when you noticed that I was struggling, which then I come to the coffee morning weekend and then I met up with Michelle and just right, I think I need to start seeing you, obviously weekly, monthly, however.
Separately or together?
Separately. Yeah, so that's when I started then having my regular appointments with Michelle.
I don't think I could have gotten through the issues that I was struggling with on my own, for sure. There's no way I could have coped and got myself through it just purely by myself. I think having somebody there that you can say exactly how you're feeling, and they can see and give you the guidance to help you through those feelings, I think is second to none. There's no way I could have got through it without the face-to-face help.
As I found as Dad was getting better, my anxiety was getting worse, and obviously it was I think I'd bottled everything up and I'd just gone to survival mode when Dad was really ill. So when he was getting better, I think that was just slowly flooding back in. And I went to my doctors and they put me on tablets, fine, I get it, but without addressing the actual problem, I was never going to get anywhere. So yeah, by seeing Michelle actually and picking everything and going through every little detail. Why do I feel like this? Why do I feel like that? And actually looking at the logistics of it, that definitely helped because yeah, again, I don't know, we wouldn't be hiking or nothing. We would be inside. We wouldn't. There's a lot of things we wouldn't be doing.
We still wouldn't be a family, would we? Yeah. And I would probably still be locked in the house, not going out, not not speaking to the girls, or they probably wouldn't have been coming in, seeing how I would have still been so coiled back, if you like, recluse. And I think, yeah, being locked indoors all day, too scared to go anywhere, I think is, you got to go out and have a bit of fresh air to help yourself. The end result for me, being able to speak to Michelle, was brilliant. Really was. They give me my life back.
And give us our
Yes, as a family. And as a people, give us our life back.
Sorry if that was a bit too powerful. It's a really emotive topic. But that was a COVID case, but most of our families are hard hit like that. So, but I just want to say thank you. These are all the people that helped me in the pandemic. This is my redeployed team of family support, and I will always thank them and continue to thank them for decades down the line, because we couldn't have done what we did without these people. And these are my fantastic team now. So thank you very much for listening.
Michelle, thank you for that. It was incredibly powerful story, and not just from the human perspective, which I think is really important for us to capture and to appreciate in our board meetings, but to see, you know, the impact in terms of the service that has been delivered. It really is quite remarkable. And what struck me listening to Michelle and Russell, I'm just wondering if we can get perhaps either I could, perhaps it would be very good to come from me, but I'd like to perhaps get back in touch with them to say thank you very much for contributing to this work by having their story told, because I think their story has had quite an impact this morning.
Yeah.
Okay, so I'd like to do that. So we'll be in touch about perhaps dropping them a note to say thank you very much, because I think it's very hard for people who've gone through all of that.
It is
To try and sit people down and to encourage them to tell their story. You're asking them to relive it, and that in itself is quite dramatic. So I, as chair, I really appreciate the fact that they've been able to do that, and clearly to articulate that human side of it. Any questions? Lauren, I'll come to you first.
Thank you. Thanks, Michelle. Fantastic presentation. I think that patient story really clearly articulated the impact from a patient and family point of view. But Ian and I went round one of the intensive care units, and the value that the staff place on it came across really strongly.
They did.
You know, the amount of support that there was for them and how they supported each other, but also dipped into the offers that you've got. So thank you for that.
Thank you. I would have given you a staff story, but I don't have enough time.
See?
Is the service available to people who are not necessarily on intensive care? So if people get really acutely ill and are not transferred to intensive care to sense anything that can be done for them, is there any services available to families, those people?
There's definitely an unmet need. The answer, sadly, is no, there isn't a service. There's lots of areas where health psychology, I kind of come under the hat of health psychology. There's lots of areas in medicine where psychologists can help at the inpatient stage, helping families and relatives and the patients engage better with staff. We know that there's often a block there when you're critically unwell, you lose motivation, you disengage with therapies, and that takes not longer to rehab people than necessary. We also know, again, preventative wise, we're talking with the gastrosurgeons. We know there's a lot of preventative stuff that could happen with changing health behaviours and helping them to engage earlier with preventative medicine. But we're at capacity just with critical care patients at the moment, unfortunately. So there's lots of people that are coming to us asking, but it's a tight financial situation at the moment, and it's definitely needed, but we can't provide it, I'm afraid.
Thank you, Michelle. Absolutely brilliant. I've got a couple of levels I want to ask them. First of all, in relation to the work that the word is critical care, what happens when the people, the clients that you deal with, go from being critical to, if I use that word, ordinary care? That's normal stuff, if you know what I mean. So I was going to, have we got a structure there? And do we link in with the voluntary sector? Because you mentioned the coffee morning. I wasn't sure when Russell was talking. Was that something that you and your team had arranged?
Yeah.
I'm conscious it's great we're going on in the community as well, so that you've got this sort of at some stage you can let the steam off the pressure cooker off with you, and there's a handover to someone else.
Absolutely. So when we identify, so all inpatients on ITU are screened, as I said, within 72 hours of being desedated, so woken up from an induced coma. They're all assessed for psychological risk, if they are deemed at risk, and we've got very sensitive measures that help us to detect that, then we will develop a care pathway. It goes with them to HDU. If they step down to level 2, it goes with them to ward level. We do an outreach service. I can't do it for their entire admission. So Russell, for instance, 4 months isn't unusual for every week on intensive care. It can take a month to recover. So, 22 days stay, you're talking about a 3-month rehab. That might all be inpatient. We can't do that. So we tend to step down to the wards with the patients for about 2 weeks. That step down from one-to-one care is very anxiety provoking when you then go to ward-based care, where it's 8 to 10 patients for every one nurse. So we tend to do that transition period. The second safety net is then that we have every patient that's been on intensive care for 3 days or more on a ventilator is automatically offered a follow-up with an MDT clinic. So that's an intensivist, a physio sometimes when we can get one, a nurse and psychology. So there's another safety net to catch them if we either miss them due to them being discharged too quickly, which we want, but then that means we can't get there quick enough. So there's another safety net to see them. The coffee mornings is something that's been done for a long time. There's a charity called ICU Steps. They do some brilliant information with our families. They promote the coffee mornings as a peer support way of giving that for survivors and their relatives. So we were running those prior to the pandemic. We have restarted them. We've got the Welsh National Opera that's coming to help them with chest physio. We've got, we do neuro rehab type workshops for the patients, but a lot of it is just informal getting together, but it is extremely valuable, and we get the patient feedback and we take the feedback to shape the services from the experiences they've had along the care pathway. But we are looking to liaise more with charities and third sector, because we know there's an awful lot out there we could do with rehab and prehab.
Can I just have the supplementary on that? As the veterans champion on the board as well, when we deal with our veterans, and you have veterans in, I'm assuming that the linkages with Mike Moore, who's leading on PTSD and all this stuff with veterans.
So I'm actually working with John Bisson's team as well. So I'm working with the trauma stress Wales service, and with Will, who is one of the psychologists who works with the Veterans Service. So we've got very good links with our mental health colleagues in the community and in some of the specialist services, and we're developing specialist trauma care pathways. But there's more we can do. It's just knowing who's out there and where.
Thank you, Chair.
So I just wanted to address the issue of continued funding. You made a brilliant, compelling case here, right? It was a fabulous presentation, really great. But obviously this is dependent on charitable funding, and we've just done some work with the charitable committee, haven't we? Which means you're all right for the time being. But I suppose question for you, it'd be a terrible shame to lose this service.
Yeah, so yes, agree. I mean, and Michelle will remember that we had quite a lot of machinations with Michelle when we were trying to get this, because it was back in the days of the ILGs, and we were trying to get people to contribute bits of money from different pots, and it was all a little bit complex. I mean, absolutely, yeah. And there's no doubt this service is a hugely beneficial service to our population, our patients, and I think there's clear need for us to look at how we substantiate the funding. One of the questions I was going to say to Michelle was, there's a lot of data there, Michelle, about activity, the referrals and numbers. It'd be really helpful, I guess, think about the outcomes, because you described a lot of the really positive outcomes, but how do we describe that in sort of both from an efficiency perspective? I'm also thinking, Philip's here from public health, that this ticks a lot of our boxes around, intervening now intensively will enable us to then stop people needing more longer term ongoing commit. So there is an efficiency down the line,
Yeah.
and you described the thing about, you know, otherwise, in fact, that Charlotte and the thing, I got prescribed antidepressants, but actually didn't do anything because he hadn't actually sorted the source problem. So there is something about how we describe that you describe the end-to-end pathway, and maybe feel there's something about with working with Michelle, looking at what's the public health benefit of these sorts of things, and
Absolutely.
health economics benefit.
Exactly, that's what I was going to ask you. I could do a health economist, please.
Yeah.
I can give you the narrative, I can give you the numbers, but in terms of the clever stats, I could do with some help.
Philip might be able to find help. Yeah,
And I mean, you didn't present a staff story, but we know that is bubbling very shortly under the surface. Right?
Absolutely. And to be fair as well, when I approached the staff, they weren't confident about having it presented to board, which also says something about psychological safety as well. But so I had some quotes that I was allowed to use with permission. But definitely, I think there's a lot more.
And clearly, we have the wellbeing service within the organisation, but
Yeah.
certainly linking with your.
We do. Well, the reason why we had it on a frontline service, because the literature says that we need a more responsive, you know, Claire's team have got 13,000 members of
Yeah.
staff to look after. What we need is a hot debrief when something critical happens, and we need that on the hoof. And the staff are offered the butt canopy, the wider service, but what they said, we want someone who gets it. We want someone who knows what we're going through, who can be responsive to our needs now, but also just knows what critical care is.
Get in then, Gerard.
So thanks, Michelle, and you know, having spent a lot of time with you and the team, see it in action, and what we're able to offer. You know, a family member of mine had an intensive care stay in a different organisation and has had significant trauma, has had nothing from an ITU admission, and has had significant trauma undoubtedly from that stay. And it is that important piece, isn't it? We've got to now land the business case to ensure the ongoing funding for this service is absolutely crucial. So very much not just for our patients but also for our staff, and I know how impactful your input and the team's input is with so many of our staff, and I think that's you know, just massively important, and you know, is part of why, you know, we should be really proud of our ITU services within CTM. So you know, absolute commitment to land that business case, and Philip and you know, building with some of the health economics and the wellbeing services as well. So we'll work with the care group and land that.
Gerard.
Yes, hospital chaplaincy obviously for years has done a lot of work in building on Mel's point about the voluntary sector on a less clinical level, of course. But could you say a little bit about how your work sort of supplement or, you know, works with the very important work that the hospital chaplaincy teams do?
You probably saw in the last slide, there was quite a few
Yes, I
people
did,
in
I did,
chaplaincy
that's
service. Absolutely. So we linked in with them, and as many staff were shielding in the first wave of COVID. So that, again, it launched me into so many different services that would have taken me probably years to get to know. So we've got very strong relationships with chaplaincy service, basically because of that first stages. We still work very closely with them. We cross-refer between us. We're looking at spiritual, emotional, psychological and physical healthcare needs. We're more holistic than we ever were. The pandemic really did, in many respects, do at least our service a good favour in terms of getting those connections and networked really strongly. So yeah, we do, and we share that out. So some of our debriefs, we bring the chaplains in, having that holistic understanding of your patient's care and sharing that workload. There aren't that many chaplains either across all the sites, let alone there's only a handful of psychologists across 3 sites. So it's really important we have those links, and we do support each other very, very strongly.
Thank you very much.
Thank you. Okay, thank you. Any other questions to Michelle? No. A huge thank you. That was a superb presentation, and that balance between the human story and the hard data, the information around the delivery of the service itself. Thank you, Michelle.
No, thank you all.
Thank you, Michelle.
Thanks.
Thank you.
Oh, amazing. Can we take a 5-minute break?
Yeah.
You okay?
Yes.
No, we'll pause for 5 minutes. So yeah.
Yes. Incredible.
I'm remembering, because we went to walk around UHB. Do you remember that?
Is that better? Is that better? Yeah, yeah, yeah. Thank you so much for your help. Thank you.
Okay, ladies and gentlemen, we'll reconvene our board meeting. Thank you very much indeed for your patience. We'll just move on to item 4, and if I can just deal with the chair's report first, the fixing the common seal, but also the chair's urgent action that was taken since our last board meeting. Now, there were 2 items that I covered off in my report. The first was in respect of managing our financial position. And can I just say that, as I've said on numerous occasions before, but I'll repeat it because it's important to restate it. My huge thanks to Sally, our finance director, and her team. This remains still very much a very challenged financial year. The health board collectively, amongst our staff, our leads, our exec team, have done a huge amount of work to find ways of making what we do far more effective, but very much more efficient in how we use public money. And we must always remind ourselves that it is public money that we are spending as a health service, and we try to get the best bang for their buck. And getting us into the financial position that we're now in has taken a huge amount of effort on Sally's part and her team. So huge thanks to Sally. I wanted to restate that in my report because it is important that we convey to the public our understanding and our efforts to attempt to be better at what we do with the resources that we have. And that is difficult. That is not without challenge, but I know we are all very conscious of that. I also wanted to reflect on the amount of work that we're doing as an organisation to demonstrate how we value our staff. At the point of writing this report, there were more than 650 submissions from staff for the CTM Serum Awards. That is a remarkable achievement, demonstrating the value that staff members place on their colleagues. A huge amount of work that we've done by Simon and his team. And as we've stated, we're now preparing to hold our first long service recognition event in January for those with 40 or more years of NHS service. And there's a huge programme of work behind this. And I think this is absolutely the right message to send to our staff about the value that we place on them. It's not just this, there are other things, of course, that we do and seek to do to show that we value our staff. In this, I have mentioned 2 people because I wanted to do it today. It's really important for me as chair to mention the fact this is our last board meeting. Our Executive Director of Nursing, Professor Greg Dix, has been awarded a Lifetime Achievement Award at the Nursing Times Award ceremony in London. And Greg was nominated by our own Chief Nursing Officer. However, actually, the nomination for the event itself, for the support for Greg's award, came from the 4 Chief Nursing Officers of the United Kingdom. A huge achievement. Greg, congratulations. Fabulous, fabulous results. But also our Chief Pharmacist, Hannah Wilton, has been recognised by the Royal Pharmaceutical Society with a fellowship. Again, I think these are stunning results. It's important to highlight, promote and celebrate this achievement. I think collectively the NHS has been rubbish for decades in celebrating what our staff do. And the more that we can do to achieve that celebration, that achievement, is not just around improving levels of retention, but also encouraging generations of staff in the future to want to come and work in CTM and to want to work in our health services. So, please let me know and let the board know when we have these sorts of fabulous occasions that we want to celebrate.
Thanks, Chair. I mean, congratulations, well deserved, Greg. I think we need to note as well, we've recently had 2 of our healthcare support workers from Tillydard who were awarded the healthcare support worker by the RCN in London, which, unlike the Nurse of the Year in Wales, they're only nominated in Wales. These are nominations from all 4 countries. So it's a fantastic achievement for 2 of our healthcare support workers from an area that previously has had difficulties. So I really think we need to acknowledge them too.
Thank you. Absolutely. I think it was just a sequencing of timing. So we can get that.
Sure it is, but
you're right, Nicola, and we've done some PR about that as well, haven't we, internally and externally? Because as Nicola rightly said, not only is that the prominence of being a UK-wide, but the fact that those from a unit that's had some really big challenges, and a really another positive endorsement of the improvement work that's happened at TTD as well, which is fantastic.
Yeah, thanks, Nicola. Any questions on the main items of my report? There are a number of items for which my signature was required, and the use of the common seal. I've never signed so many documents in my entire life, but all of those are really important in terms of the work that we are developing. And there was Chair's urgent action around the UK COVID-19 inquiry, Module 5. So the decision on the application of core participant status. Are colleagues happy to note the report and to endorse the affixing the common seal?
Yep.
Yep, thank you all very much indeed. Okay, item 4.1.1, the action log. Since the last meeting of the board, the report is there for colleagues to note. Any questions just in terms of progress on the action log? I'm happy to note. Okay, thank you very much. Item 4.2, Chief Exec's report.
Thank you, Chair. I just wanted to draw out a couple of points from my report. First of all, just on the escalation status, as you know, we are currently in enhanced monitoring for planning and finance, centering the enablement of quality governance, and TI for audits, particularly around waiting time. We've had a very positive meeting a few weeks ago with Welsh Government around targeted intervention, and I think a recognition for colleagues in Welsh Government of the significant improvement that is happening within our performance. And also yesterday, a number of colleagues had further conversations with the Welsh Government, particularly relating to quality governance and maternity and neonatal services, to provide further assurances and information, which we are hopeful will enable at the next tripartite meeting with HLW and Audit Wales to potentially look at a further de-escalation in those areas. So we will wait to see that meeting on the 18th of December. Also important, I guess, to think about the fact that we've also just recently had a positive, what's it called? That's the one. Structured assessment from Audit Wales, which I think was highlighted still some further areas of development. I think was a positive description of many of the changes that improvements that have happened particularly around our governance. So we will wait to see what the outcome of that meeting is, but we are hopeful that we've provided sufficient information and support to Welsh Government colleagues to be able to inform that decision-making process. The Chair's mentioned the financial allocation that's come through from Welsh Government, and Sally will no doubt pick that up when we pick up in the finance report. And also just wanted to say that we had a very positive session with local authority colleagues a few weeks ago, and Matt Jenkins has joined us from Welsh Government as a joint appointment between CTM and 3 local authorities to lead on the work on further developing the joint working between our local authority colleagues and ourselves. And we have a number of areas that we've agreed to pick up, 2 particular ones, one of which is what is it we as a combination of health and local authority are looking to offer to our communities, but also what do we want our communities to support us in doing. So something about how do we get that balance of trying to shift the focus around self-responsibility for certain things. You know, we can do, it's a bit like, this has worked very successfully. They've done this in Wigan, in Northern England, where the council and the local health services said to the communities, we will undertake to do this for you, but what we need you as citizens to do is, get your vaccinations, ensure that your children are attending school, making sure that you're doing this. So it's trying to sort of redress that sort of slight imbalance that we sometimes find, where perhaps some communities feel that they're passive recipients of things, whereas actually what we want to try and do is say, how do we as a health service and local authority colleagues provide you with things, but on the proviso that you also take some responsibility for your health and well-being. So we're just working that through with colleagues in the local authority about how we might be able to do that. And obviously that would be something we'll engage with wider community stakeholders on as we go forward. And the second area of focus was thinking about how we use the population health data that we have available to us moving into the winter period, picking up plans for how we might target interventions to the most complex populations by practice, and how do we develop a joint health and social care response to almost proactively anticipate the needs of those individuals so that we hopefully can avoid them getting worse, escalating and needing hospital admissions. So two very practical pieces of work that we're working on there, which is positive. Operating model is in final throes of the appointment processes to the roles at the next on phase 2. A big thanks to colleagues who've worked really hard on this. Matt has worked very hard on it with Helen from Hal's team, Rich from Greg's team, and colleagues in the ops teams. A lot of work and energy gone in from my executive colleagues on interviewing, but I think we are getting to a place now where we will be able to make appointments imminently into those roles, which is again a really big step forward into the next phase of that. And also just to say that the work on the new joint commissioning committee for Wales, which will bring together the functions currently held by WISC and ESC and the National Commissioning Support Unit, but it continues at pace. There's a lot of work going on that at the moment, and you'll remember that we as a health board host all 3 of those bodies at the moment, and we will be hosting the new joint commissioning committee as well. So whilst we're all as 7 health boards having a lot of input into it, we as CTM have quite a significant more input into it just because of the nature that we host. So there's quite a lot of work going on that point as well. And just to pick up what John said there around the Severin Awards, we, as you said, had a lot of people nominate for those awards, and I'm pleased to say that we've actually literally yesterday confirmed the first Severin of the Month winner. So that is a lady called Louise Wheely, who is an advanced nurse practitioner who leads the HIV service for CTM. And she's had a very strong application, or one of her colleagues nominated her, and it was a really strong application for somebody who's led a service for a population of patients who are often quite marginalised. So the fact it's somebody who's driven that service through came across really strongly in the nomination. But I have to say, having seen those nominations, it's really hard to pick one person because there's so many amazing, and I guess that's the real benefit from this process, is you start to draw out a huge raft of different stories. And I think there's something about, rightly, we recognise one person as the winner of the month, but there's something about all those stories being socialised so that people can read it. It's actually quite reassuring and heartwarming to read at a time of significant challenge in the NHS, to read so many great stories of brilliant people going beyond the call of duty to support the patients and support their colleagues. So really great to see that. So that's what I was.
Great news. Thank you. Carolyn.
Yeah, thank you. Thanks for that. I just wanted to raise an issue about the acute clinical services plan and your mention of the all-day event for senior medical staff, which is obviously very positive. But could I just ask you to say something about that gives us assurance about the multidisciplinary engagement into the clinical services plan?
So yes, absolutely, Carolyn. And just to say, this event wasn't an event where we said, oh, we're going to get all the doctors together to talk about the clinical service plan. It was a seminar sort of event that we had already in the diary sort of every 6 months, which was opportune that we used that particular one to talk about this topic. But you're absolutely right. And indeed, many of the conversations at that day were about the MDT that would need to be involved in this. What's happened the outcome of that day was that the care groups are now taking the work forward, not just with the medical staff, but with the nursing staff, therapy staff, and everyone else involved, the ops management teams, everybody. So just to reassure you, there absolutely is a multidisciplinary approach, and yeah, it was a useful conversation. But yeah, the future conversation has got to be very clearly multidisciplinary.
Thank you.
Greg, and then Simon.
From a nursing perspective, Carolyn, we have professional channels of communication with our ward managers, our senior nurses and our lead nurses and heads of nursing each month. And so we've been socialising the initial CTM 2030 and then the beginnings of the acute clinical service plan through those professional forums. So not dedicated sessions around the CSP, but definitely part of that professional communication. So they are linked in. I think we could probably do better by having more of an MDT approach, as Paul's just described.
Yeah, just following from that, one of the things we talked about last week as the execs was how we construct the right forums where sort of heads of department, senior leaders from across the organisation, of all professions, can come together more regularly. You know, we're still in the sort of getting to know the new world post-COVID, I think, and there's something about we acknowledge that we perhaps could do with a couple of times a year having, I don't know, the top 150 sort of senior leaders, clinical and non-clinical, coming together to talk about some of these topics in a broader sense. So yeah, absolutely fair point, Karen.
Sam.
I was just going to mention that this afternoon, Carolyn, myself, Dom, Lauren, and Greg are all getting together to do a bit of mapping to look at what are those touch points, particularly with the clinical and therapies and health sciences teams as well, so we understand what are the opportunities we've got to engage with those people. Because there's so many touch points, we need to make sure we're using the right kind of groups and using them as most effective way.
Nicola and then Sally.
Yeah, thanks, Chair. Just picking up on the long service recognition award. I'm really pleased to see that there's something in place. I just got 2 asks. Most of our staff who've worked 40 years plus will have retired and returned. That probably is not recorded on ESR showing the length of service. So can we be sure we capture them? Because there's nothing worse than you hold this event. You've got half of them missing. And also, many of our staff who work at the point of care, their rotas are completed 6 to 8 weeks in advance. So this is the 17th of November, which January could fall into that window. So can we communicate it so we can ensure that we can support people to attend, please?
Okay.
Yeah, so you're absolutely right, Nicola. We're aware that there are some people for whom ESR doesn't capture as well. So we're working with the team just to try and identify who some of those staff may be. Because you're right, the worst thing would be to celebrate the fact we're finally doing this and to miss out huge charge to the people. So we're doing that now. The letter is written and ready to go as soon as we're confident that we've got those people within that distribution list there as well. So ideally this week, but yeah, we need to get it right first.
I also think there's something as well about us saying to line managers, can they do whatever they can do to accommodate that person attending? Because it's really important.
Yes.
So we need to perhaps, there's a note to line managers in our regular leadership bulletin, I think.
Yeah. So Sally.
Yes, to come back to the Senior Doctors Away Day, Hannah Wilton, the Chief Pharmacist, and also Lisa Lovell, the Clinical Director of Therapies, were also present and involved in a lot of those discussions. And as a care group as well, being DTPS, we have asked to be involved in the conversations with the other care groups at an early stage, because there's a lot of support that we can offer, particularly from a pharmacy point of view, which will help transform services.
Thanks. Any other questions to Paul on his report? Okay. Or notes to report. Thank you very much indeed. Okay, we'll move on to item 5, the section on delivering our planned integrated performance dashboard. And on the first part of this, I'll come to Linda in the first place. Thank you.
Very minor. I think we've now made that requested differentiation around red release responses. So the numbers are there and a bit of a descriptor in that I've requested. No other changes to the report. So I guess I'll hand over to Gethin.
Thanks,
Lovely, thank you. We'll take the performance reports as read. I'll just draw out a couple of key aspects, focused predominantly on the targeted intervention areas that as people were alluding to. So the first is around our mental health services, and we have 2 areas that are in targeted intervention there. One is CAMS, and it's pleasing to see the continued improvement in the 1A compliance, and in part 2, which is exceptionally positive, and 1B, which is then the follow-on, because we're now managing patients through the 1A process far more quickly. We're now having to play catch up on the 1B section. And it's good to see the number to date in November is now at 48%. So we are beginning to see that continued improvement in our 1B performance. So CAMS very much improving significantly. Psychological therapies. So again, we continue to be challenged in that area. We're at 58% now in terms of compliance, which is the highest we've had for several years on psychological therapy, and our longest waiting patients have now dropped by 20 weeks. So we've seen that number now drop to 140 weeks. So again, working through, there's a lot of effort on balancing the service across the health geography. We've got quite significant differential weights across the 3 localities. So Andrew Davis, our chief psychologist for mental health services, is now balancing and beginning to see the impacts of that. Just to draw on adult mental health, because those numbers have dropped, they are now returning back up in November, and the service believe that they are on course for compliance within Q4 of this financial year. So seeing that improving back up. On emergency care, as you know, we're in targeted intervention for ambulance handovers and also for emergency department performance. So in terms of handovers, we had a more difficult period in October than we had experienced previously, but I am pleased to say that despite that, we still managed to reduce the lost hours compared to October 22 by over 2,000. So we continue to perform well. And I think it is important to note that since August, we've been second to Cardiff in August and September. We did drop to third, just behind AB in October, but in November now we're back into second position. So whilst we are not where we want to be for ambulance handovers, our performance now has set us in a much stronger position. And in November up to today, 68.5% of ambulances have been offloaded within an hour. So again, real testament to the focus and drive of our hospital teams to ensure those ambulances remain on the road. In terms of ED 4-hour performance, for October, we were at 64.32%, which is below our recovery trajectory. However, is a significant improvement on the 61% we were in October 22. And to put that into context, that's 1,300 patients in that month that we saw within 4 hours, greater than that period last year. So we are seeing a significantly larger number of patients within 4 hours because of the growth in attendances. So again, testament. We have had an internal audit report around the way in which we record that, and we are and so there are a number of actions that are being put in train to ensure that our validation process for our monitoring is far more robust, and I suspect when those actions come into train, we will see that performance improve. In terms of planned care, as you will see, we have continued to see a significant improvement on our focus of treating our longest waiting patients, and CTM is in terms of the larger health board, so excluding Paris, is in second place now for the cohort of patients we've got over 104 weeks. We were bottom of that pile at the beginning of this year. So again, a real strong focus from the operational teams to continue to drive the reduction in those long-waiting patients. In terms of cancer, our performance, as you'll see from the report, remains stable. Which is positive, and it's stable in the context of seeing our over 62-day cohort now constantly coming down. So our longest waiting cohorts, we are reducing the volume of patients. So it is being, whilst we treat those patients and take them off, we are also then seeing some improvement in some of the other areas. We have a real focus on 3 key tumour sites, which I've discussed previously. The first is around urology, and the key focus there is the implementation of a new hematuria pathway. Grateful to colleagues from X-ray who've supported with the rejig of that. So that will support urology performance quite significantly. We've got additional capacity in at the moment for endoscopy to particularly focus on our lower GI weights and the pathway for bowel screening Wales patients, which is the key challenge in that pathway. And breast, as you know, we will be bringing the whole breast service together at the Royal Glamorgan in time for the 1st of April. We have a second issue which is causing a real challenge around the treatment of breast cancer, which is around the provision of radioactive isotopes. So a really important element within breast surgery. The Cardiff service has unfortunately lost its license, and therefore we have very limited access to radioactive isotopes, which are a significant part of the central node treatment within breast cancer. So we've got a number of mitigations in place, but it is slowing down our ability to treat patients there. And just to also touch on the continued improvement in diagnostics. So the board will be aware that at the beginning of the year we had over 10,000 patients waiting over 8 weeks for a non-obstetric ultrasound. That figure is now down to 5,000. We continue to see that reduction month on month. So again, massive thanks to our sonographers who are really supporting us in the delivery of that. And as part of LHP, we will have additional diagnostic capacity coming online, which again will support us in the reduction of our MRI waits as part of that programme in the final quarter of the year.
Thanks, Catherine. Okay. Greg and Dom. Yeah, I'll start first. Yeah, thank you. So from a complaints perspective, then we have seen a bit of a dip in the 30-day compliance last month. It kind of was expected because we're still focusing on clearing the backlog of complaints. So in April, there were about 165 complaints over the 30 days, and our trajectory by the end of this year will be down to 20. So the team have been focusing on both the backlog of complaints, which clearly then are out of compliance in terms of reporting, and the complaints currently within 30 days, but they're doing a really good job in that regard. We are clearly keeping people that write in to complain updates of where the responses are. And we have family liaison officers for new board members that support patients through this complaints process. In relation to the wider learning, we do have a listening and learning framework, and happy to share that again with new board members so you can see how we share learning across the organisation. It's reassuring to see the continued reduction in our formal complaints. With lots of work over the last couple of years in relation to this, particularly the new process of a 2-day inquiry process where we close down the complaints, generally with a conversation or face-to-face meeting with people that raise a concern, as opposed to undertaking large investigations. And sometimes people just want to have a conversation about their care. So lots of efforts in that regard. And very recently now we have a full PAL service, so patient advice liaison teams across all of our hospitals. So they're there to support any particular issues and to ensure that early resolution happens, as opposed to going down a formal complaints process. So I'm pleased with where we are with complaints. We will see a further dip next month in compliance because we're clearing the backlog, but then from the beginning of next year, then we'll be back up to 75% plus. And we have informed our regulators in that regard also. Board members may recall the last time I was talking about infection control issues. I was concerned about our rise in E. coli rates, so particularly patients that have urinary infections and catheter care. You'll see in the pack that our rates have started to reduce, and they're tracking last year's performance, still not where they should be, but definitely better. I think two things has helped here. The first thing around raising the profile of catheter care with our inpatients, but particularly a big focus on ANTT. So that's aseptic non-touch technique. So doing wound dressings essentially. So big focus on that and training, particularly through all of our staff, not just nursing. The step up in our NRI reporting, you would have seen in the graph. So NRI's nationally reported incidents, so our most serious incidents, there has been a step up. That's due to changes with the national requirements for reporting infection control ward closures. So it's not that we're having more serious incidents, the reporting is different. And we have, over the last couple of months, closed various wards due to both COVID and norovirus. So we now report those through the NRI process. And finally, for me, the board was rightly concerned around our NRI backlog. That is reducing. We're down to 70. We're still nowhere near where we should be. We do have a planned reduction trajectory in place, which is tracked by all of the clinical execs during our patient safety meeting on a Monday, and we will clear that backlog by the end of March. And nothing else from my perspective, and I'll hand over to Lauren.
Perfect, thank you. A few headlines from me. So you'll see the stroke slides in the performance dashboard. So there's an upward tick in terms of the admission to a stroke unit within 4 hours. But as we know, this performance correlates with the general acute services that get been spoken to. Our thrombolysis rates, so we're best in Wales this month, but these are small numbers, so I think it's just to draw people's attention to the fact that there will be significant fluctuation because of that. Some of our other metrics are fairly static. You'll see that we've introduced an early skilled discharge metric. So there's been some investment in the stroke service this year. So we've introduced this metric. The recruitment's underway. We've got induction and pathways and processes being written now. So we're expecting to see that impact towards the end of Q4, start of Q1. And there's been a refreshed governance structure and ops oversight. There was an updated format of the report that came to Quality and Safety Committee this month that was well received. So hopefully that should give some additional assurance in terms of the detail that's of the work that's happening within stroke services. From a healthcare science point of view, Gethin's touched on the key headlines from a diagnostics perspective, so I won't go into that. In terms of therapies, generally doing well with regards to our 14-week waits for children. We've got some PEDS-OT staffing issues that are having an impact there, but we've got recruitment underway, so we should start to see an improvement in the new year. For adults, there's a significant decrease, so a 10% decrease in terms of the 14-week waits, but you'll see that our biggest challenge is around the dietetic service, so particularly weight management. We know that's a particular challenge for our population. So there's group interventions underway, there's some expansion in the team, and there's exploration in terms of other services that we can support people into accessing, and we'll look to expand that. They're my headlines.
Sure. I'm just going to talk on the one bit which you'd expect me to, so this is page 31, which is mortality rate, so we've raised it before. So you'd be able to see that there is a downward trend, which is great, and partly that's, well, there's multiple reasons for that. Partly it's because of our attention on it and focusing on getting that data much more accurate. There is, however, we know now, one of the main reasons that our data has consistently always been higher, we found it's the way that the other health boards report their data compared to the way we report it. So we report a true admission, so our denominator is all true admissions. Other health boards do any interaction. So if a person attends ED, that's counted as an interaction. Therefore, their denominator is higher, therefore their rates are low. That is one of the other reasons why it's been going on. So there are multiple reasons, but that's just the newest one that we've realised. So we're setting ourselves up to be worse because we approach that way, which actually is the way we should be doing it, because it's a true reflection rather than a different way of doing it that the other health boards have taken. But I would just like to thank very much the digital team have been absolutely fantastic. We've been limited by their capacity, as Stu will happily tell you, but we have actually some great strides. We've now developed the dashboard for the CHKS data. So this is the comparative health knowledge system. So it's the data that's used across Wales and across England as well. We developed our dashboard for that, and we're hoping to start rolling that out, actually seeing is it work or not, trialing it and using that in data. But the main thing we've done is developed now the data set collection for our bereavement officers on the 3 acute sites. That is going to allow us, when that's in place, and this is where the digital team helped set this up, that's going to allow us to start doing this, raising the flag where we know there's particular concern in an area, and also allows us to start doing those deep dives where we're up to now, we haven't had that level of data. So there won't be necessarily be stuff that we're reporting externally on that. That data will stay the same as it is, but it allows us to have that much better internal grasp on it. So what I hope to do in the future is provide the data that is being published nationally, but also what our internal will be. It's a progress. We're at a stage on here, but it's going to take at least another 6 months to get any meaningful data collection from that. Because at the moment, the numbers are just be too small.
Thank you. Thank you. Sorry, consciously put quite a lot of data there, so I'll just pick up the headlines. So you'll be aware that there's a full workforce metrics report which goes to the People and Culture Committee, which gets a good airing, and is also, of course, available publicly as well. There's a couple of things to highlight. So I'm looking particularly at the trend line data for sickness. The in-month graph is a bit bouncy, so I think the trend line is more useful to look at. That continues to tick likely downwards, and it's getting closer to pre-COVID levels of sickness than we have done since the pandemic. So we obviously had trough in our data around about the September 21 time, but that was post second wave, a lot of annual leave being taken. So I'm not sure that's quite a reflective of where we were at that time. So I'm quite encouraged actually by the sickness data. An awful lot of work has been done around return to work interviews, which has picked right back up. That's something feedback we received from trade union partners as an area that we should focus on. So we have done, that's gone right back up, and I think that has had an impact on short-term sickness. And also the wellbeing team have had some successes in terms of returning people back from long-term sick, and obviously long COVID sufferers as well among our workforce. So we'll continue to keep an eye on that, but encouraging signs there. I would say, however, returning to pre-COVID levels still returns us to around about the 6% mark, which was among the highest in Wales, and sickness in Wales generally is higher than NHS trusts in England. So that doesn't mean we're sorted if we return to pre-COVID levels, and it still means we've got some work to do. Turnover, we reached our peak, I think, a couple of months ago on turnover. That is coming down from peak, but remains stubbornly high around the 11.5% mark. We have now agreed 3 or 4 very specific actions around retention linked to things like flexible working. We've just had a new flexible working policy released by NHS Wales, the emphasis for which is on accepting the request rather than the other way around. We're also doing some work on internal moves, which we're working on in partnership with Nicola and a couple of others. We need to conclude that process pretty quickly because we've had feedback that around 58% of our leavers have said that had they had somewhere else to go internally, they wouldn't have left us. So we need to listen to that. And we're also doing some work to simplify termination procedures so that we haven't got managers filling in 3 or 4 forms and staff filling in 3 or 4 forms. We've got one single process that asks some really simple questions about why you're leaving us. So we're doing some work on that as well. Just briefly as well, I wanted to mention mandatory training compliance and PDR. They're not quite where I want them to be, but our trend line is continuously upwards. The challenge with those things always is, as you're getting people through them, people are dropping off. So if you're continuously improving, I think that means we're doing something in the right direction. We're at around about the 77% mark on Core 1 compliance, which is not bad going considering where we were 2 years ago. We've made a 10% increase steadily in PDR over the last 2 years or so. Not enough, not fast enough. But as I said, people will be dropping off as they're also having their PDRs undertaken. So I'm encouraged by that. We just now need to continue the focus on those things because we know that there's a massive link between positive outcomes in relation to retention and engagement and PDR directly and development as well. And those are probably the things I just wanted to highlight, Chair. Thank you.
Thank you. Okay. Yeah.
Yes, can I just ask about delayed transfers of care, please, on page 27, is it, of the report? So it's quite a while, it's pre-COVID since I sat on the Regional Partnership Board, which was doing quite a lot of work, and I know I've asked this before some time ago, quite a while ago, must be a year ago. What work is going on at the Regional Partnership Board level with local authorities, between as local authorities, to reduce the delayed transfers of care, please?
Linda, join us. Thanks.
Very happy to take that one. So it's obviously a big concern. It's a big concern across the whole of the UK, actually, the rise in delayed transfers of care as our social care colleagues find it harder and harder to access care workers to work in people's homes. And there's obviously also a threat to the resilience of many of the care homes as well. So the focus that we've been taking, and there's been a tiny bit of money that's come out from Welsh Government for this winter. And our main focus of that, I mean, obviously I was going to talk later actually about the fact that the RPB spends a £22 million on out of care hospital services to re-able people after they've had an admission so that their ongoing care needs are less. But the main focus of both that fund and this new money is avoidance of admission, prevention. Because if we don't, because we know that particularly older people having a stay in hospital is so deconditioning for them, that if we can do anything to keep people out, that will lift some of that demand and pressure on the hospital too.
Can I briefly just come back?
Yeah.
But before COVID, the BC, we were working together in hospital settings, mainly the A&E and throughout the hospital. Stay well at home.
That's it.
Get people back in their homes if they can, or prevent, as you say, prevent admission. The next stages were to work with GPs, pharmacists, out in the community teams to make sure that they perhaps don't even need to come into hospital. So
yeah,
I presume.
And that is exactly all part of the out-of-hospital model that is being developed. We can talk a bit more about that later on.
Thank you very much.
Thank you.
Yeah, and just to, I guess just to add to that, so we now have probably some of the most robust data for understanding our delays. We've got the electronic whiteboard in place that's being used on a live basis and generates the electronic referral form. So there's been some really positive process improvements across health and social care in terms of that. That said, and I think it is really important to put this into context, is that the number of patients at 291 is the equivalent of Prince Charles being full of patients who is no longer. So we're running with only 2 acute hospitals really in terms of bed capacity, rather than 3. I think it is a major concern with Welsh Government, and they recognise that the stuff that's happening, but that it's not reducing the volume of patients who are waiting. And I know that Jeremy Griffiths will be leading a piece of work with between us and 2 of our local authorities to understand what more can be done to expedite the discharge of patients from our beds so that we can continue to manage the rest of this winter.
It just eases everything else, doesn't it? Really? I mean, it just
And there is in my chair's report, I talk about managing our resources. If I look at our resource that's available to us, we are spending as a health board somewhere in the region, I think, of around £500,000 per week. What is it? On delayed transfer care?
Well, it's a bed day is around £350 to £400 per patient per day, and we've got just shy of 300 of them. Yeah. Beyond that.
Quick question on mortality rates. I appreciate this work is ongoing in terms of gathering the data and so on to present to us. What I was going to ask is, when all the data is in place, will we be able to see? I think I might have asked this question in another health board meeting actually. And when all the data is in place, will we be able to see it in more granular form? Yeah, so per hospital, maybe even per ward. I don't know.
What we need, we don't have that granularity at the moment. We just have a number. What I want to be able to do is to say, oh, look, we've got a spike in sepsis, we've got a spike in bowel surgery, what's going on there, and it's on this site, on this ward, and be able to track down. That's what the data we're trying to get the briefing officers to collect for us, so we can get into that, and now we can plot our trends and then jump in early when we start seeing anything going on.
You can see problems as they arise.
All right, thanks. So see you later. But it's picking up on anything else, but that's exactly the issue I was going to raise. And also, because I'm fairness, going back many months, I was sat next to Dom when I raised this issue, and I know I was supported by colleagues that the information we were having wasn't telling us anything. I just want to thank Dom and his team, everybody involved, in the journey that you're taking us through, because when we do get to that stage, it's really going to be informative, it's going to be meaningful, and it's going to tell us things that we really need to know about the way this health board is working in general. So I know I won't be around this table when it happens, but I just wanted to say now, big thank you, because what you did say you would do, and you've kept me brief. I know Q&S gets it as well, but I think it's been very positive to show the executive response.
And also hold those thoughts in terms of the conversation that Stuart's going to have with you all in February about data and digital, because a lot of the challenge Dom has at the moment is the recording of some of this information is not that easy because often working on paper records, you know, it's ferreting around trying to do clinical audits and things like that. Whereas if you have a digital EPR solution, you're able to sort of extract this data very simply and easily. So it isn't just about ease of inputting, it's also the information that brings out the back, and also the encouragement for people to code information correctly as well, because much of what Dom's been wrestling with is trying to unpick some of the coding and challenges that often, if it's incorrect, you get all these skewed data sets that get produced. So, but as you say, Mel, there's a lot of work going on with this.
Yeah, absolutely. But the team have been brilliant and digital as well. Yeah.
Any other questions to exec colleagues on the performance report? No? Okay, thank you very much. We'll move on to item 5 point. Sorry, the next item on the agenda, which is Sally's update report on the financial position. Sally, thank you.
So the report this month reads slightly oddly because of the way in which we have received an additional information. So I'll cover it off in round numbers because it's probably easier to do that than when I go into point this and point that. So this year, if you remember, we went in with a planned deficit of 80 million. And that's been our plan all the way through. And that's what we've reported against. We have continued to report that we'll deliver that position all the way through. Although month 3, month 4, we saw an increase in expenditure that gave us a risk of up to 10 million at the point against that, which is when we took action to try to bring that back into line. At month 7, performance has continued to look marginally better. I mean, it's not hugely better in terms of where we're going, but it gives confidence around that original deficit of 80 million. In the meantime, Welsh Government have said that our plan was unsupportable, and that meant that if we came to next month without having additional allocations agreed, and very importantly cash on the back of it, we'd have had to start to take cash management action, i.e. slowing down paying suppliers. Thankfully, we are not in that position, and therefore I am sleeping a little better, although the bags under my eyes don't suggest that's the case. So what we now have had notification in October, the Welsh Government have reprioritised within their own budget to enable further allocations to health boards to support the existing pattern of expenditure. So this isn't for new things, this is to support where we already were. So on a sort of our allocation is approximately 72 million. That's 63, which is allocations, and then 9, which is for energy, and which is currently being said will be issued on an actuals basis, but we'll see what happens around that, because there's still a bit more debate about that and how it comes out. So that means that from our original 80, you take off 72, which leaves us with a balance of 8, which is 10% of what we originally said as a deficit. So what we've been asked to do, and all health boards have been asked to do, is to deliver a 10% improvement so that we deliver a zero control total. We would be the only health board to do that, and that would actually mean that we're meeting our statutory duty to deliver an in-year position. So positive. It's cash backed, which means that we're in a much better position, but it does mean we've got the additional challenge over the latter part of the months in terms of delivering that 8 million. We are working on that. So when we went in for month 7, we have maintained our forecast effectively, which now looks like an 8 million deficit rather than an 80 million deficit, while we work on getting assurance on whether we can deliver the additional stretch target. Gethin and I have been working closely on that. We've got an allocation of the target out to care groups and an assessment of where they can move on what they can do, and that work is continuing. And we've also got a number of items outside of that are set out in the risks and opportunities tables, which show some other opportunities. All of that would suggest, and I think when Paul and I met with Welsh Government colleagues, they were very much of the view that we should be able to deliver the break-even target. The thing that we've flagged is that at this point there are still quite significant value of additional allocations outside of this, so for pay awards and for real living wage, that have not yet been confirmed. Those will be confirmed for month 8. And so when we get to our month 8 forecast, I'm hoping we will have that bit fixed. And then we'll have more detail around what we can do in terms of the stretch delivery. So the position as we currently sit would be an 8 million deficit. At month 8, we'd hope to move towards our break-even control total. If we deliver our break-even control total, 51 million of the additional allocation will become recurrent. So there's a real positive around delivering this and working hard to do that. So that's really the sort of high level of where we are. I'm happy to take questions, but it does mean the report looks a bit odd because we're reporting a surplus because we've had to take 7 months of the additional allocation and reflect it in the position this month.
Thank you, Sally. Just to say, we did flat, as Sally said, we had a conversation. Each health board's being asked to have a meeting with Welsh Government to talk through this allocation and how it's going to be applied. And there's a very clear steer, understandably, that the numbers cannot vary beyond what we've now got being given as health boards, because there is absolutely no way there's any further coverage within government to fund anything. So there is a real imperative for us to deliver this on lots of levels, actually. Both because it's the right thing to do, secondly because it generates £51 million of recurrent funding into next year, but thirdly also from a reputation perspective of being able to deliver what we say we'll deliver. There is that, and I think there was it felt, as much as you ever get in those meetings, a confidence from where they felt that we would be able to, should be able to. They pushed us quite hard on the terminology about confidence and optimism, but anyway, there we are. The only thing we did flag to them, which is a bit of an unknown quantity, is the risks around any industrial action from junior doctors in the new year, because clearly if that happens, there is potentially some financial risk around how we will fund covering shifts and things like that. So we have flagged to Welsh Government. That is the one caveat we've put against this, is thing that might throw us a bit off course with that. So, but I think we are in a time of particularly challenging financial environments for every organisation in the NHS, not just in Wales but in the UK. We probably will be one of the only people in the UK that will be in a balanced position, which is a place to be. But yeah.
Castle and Doc.
Yeah, thank you, and thanks, Sally, for a clear sort of understanding of where we've got to on that. And I guess we need to thank Welsh Government for the additional funding as well. But I was looking at page sort of 17 and 18 around the risks, sort of noting the risks, and as you just said, all around the doctor strike. So that's definitely one to note, isn't it? But there's still some volatility in the budget, obviously, between now and the end of the year. But I guess on the additional financial improvement target actions, the 8 million around the care groups, I just wondered, and I was going to use the word, how confident are you? But yeah, it's just a sort of trying to get a feel, I suppose, of do we really think that is going to be an achievable target? And any detail on that would be gratefully received.
So I think there is a proportion of that there are robust schemes for. And if we look at what are the top contributors to our challenge in the care groups, we know that for much of that it's driven by variable pay spend for medical staff particularly, and that's across all care groups. So there's elements of the actions that we're taking around the control environment for agency doctor spend and ADHs, and that's across all of those care groups. We are seeing a real improvement in what's happening with agency HCAs and other things, and it's are we able to accelerate further some of those developments, and then of course on some of our non-pay items as well. There are other also opportunities around some pockets of income that we receive and reviewing the anticipated allocation of those as part of that. I don't think I'm brave enough to put a percentage on my confidence.
Okay, that's fine. Just to try and get a feel of how is this achievable or not really, and we're hopeful of it.
I think we'll go with we said optimistic.
Yeah,
in terms of in the mix of the various things that we've got there, we'd have some optimism. I think the thing to just clock as well is that while some of those things would take us to a position in here, there are a large number of non-recurrent measures that have been utilised into this position and then beyond. So we still need to focus on how do we start to manage our costs down as we move into future years.
I also want to acknowledge the fact that when we went into the financial year collectively within the NHS, where we got to quite rapidly within 2 months or so at the start of the financial year was looking very different collectively to where the NHS had suggested the budget position would be at. We were different because, and I think there were reasons for that, but what we were predicting as a health board by way of an overspend at the start of the financial year is where we have maintained that position. Now, that's not been the case universally within the health service. I think there are questions there for finance directors, collectively for chairs, for chief execs, about how the NHS as a service is more robust in its planning assumptions. And I've been diplomatic how I put that across, but I just want to recognise the fact that a huge amount of work was done, again, by Sandy and the team and the exec team to look at those figures, to ensure robust planning, that what was predicted at the start of the financial year is really what we have maintained as a health board as we've gone through the financial year. Now, that's taken a lot of work. Now, obviously, in an ideal world, we'd like to see the resources match the demands that are placed upon us, and that does provide a significant level of challenge. There will be challenges in future years because the growth forecasts for the United Kingdom for the next 2 financial years have now been downgraded. The growth forecast has more than halved now for the next 2 financial years. So there will be an ongoing challenge to public services, regardless of what may happen next year in a general election. The growth forecast has dropped significantly. So just be aware, whilst a huge amount of work has been done this year to attempt to steady the ship, further work will have to be done next year and the year after, whilst we are at the same time attempting to revise through our acute clinical services plan and other measures to revamp and change what it is we do and how we do it. So, but all this is indicative of the need to get that longer term piece of work done that makes what we do far more efficient and therefore far more effective. Councillor Hopkins.
Yes, well, I just will make a quick point. I just hope that, the early Christmas present, shall we say, doesn't allow us or doesn't encourage us to lose sight of the need to do things better in more efficient ways. Because, as you say, the pressures next year are going to be no less than they are this year, if not higher. And but I did notice a certain lifting of Sally's mood in that.
In terms of the cash position, nobody wants to be in a position when they have to slow down payments.
Absolutely not.
But also, I think it takes back to the very early conversation about the strategy, because actually the long-term plan is to how do we make a strategy, how do you develop a strategy for our organisation and for our communities that delivers better health outcomes at a lower cost?
Yes,
and that's the fundamental basis for why we need to redesign, because that's how we're going to deliver our medium to longer term financial standards.
I was only going to make a very sort of point forward. I was going to talk about industrial action, but Paul already has. That my only point would be that that is going to affect the whole world. It's not just by health or health board. The only issue that we will have slightly different from the others is that we have a high number of SAS doctors, and the decision is whether the SAS doctors go on strike as well. So if it's just junior doctors who go, we'll be in a slightly better position, slightly relative to the other health boards, but we have to wait and watch this way. So that's the cavalry on the hill we've got to see that way.
Be worth me just so in terms of the additional allocations, additional point worth making is that they, apart from energy, they've been allocated out on a fair shares basis based on formula. And that means because we did the work at the start of the year, and it was some very difficult decisions weren't there around how much we would spend, what we would invest in, and how we would contain our position to the 80 million, which sounds like a very big number, but we did have to work hard to contain it. When the allocations have come out on a fair shares basis, that's why we now look like we're in a better position than others. It's because of the work that we've all done to hold our position as much as we can. Yeah.
So, any further questions to Sally? No. Okay, thank you. We'll note the report, and thank you, Sally, for presenting that this morning. I did say we were going to take a slight break, but are colleagues happy to continue for longer? So I'm conscious we've got a fair bit to get through this morning. Okay, item 6, governance risk and assurance section. We've covered off the escalation status update and the chief exec report 6.1. So I wasn't proposing to go back to that unless there were any questions on that the colleagues missed out on asking earlier. No, okay, thank you. Item 6.2, the board assurance framework, and I'll ask Gareth to present the update report to the board. It has gone to the ELG on the 13th of November, but it's before the board for approval. Thank you.
Thanks, Chair. Yes, so the report before you this morning is a standard, the report we bring to each board meeting around updating board assurance framework. As indicated in the paper, the assurance framework itself is underpinned by the organisational risk register. And just a thanks from me and my team again to everyone involved in ensuring those risks are updated in good time, both from executive colleagues and also the input that both the Audit Risk Committee and the other subcommittees have in overseeing and framing challenging those risks as well. As John said, today we're looking for approval from the board for the limits update to the board assurance framework, and we're also looking at approval for reducing the likelihood of the finance revenue resources risk from being realised, which builds on the discussion which we just had at the Sally's item around being able to achieve the £8 million stretch target 23-24. So the aspects we're looking for reducing that likelihood of score, and also overall in terms of the updates of the board assurance framework. Thanks, Jen.
Any questions to Gareth on the updates? Mel, and then
it's just an observation, and I appreciate Phil's view on this. But it's looking at risk, community and partner engagement risk 5. I'm surprised that we haven't moved, because we've done a lot of work over the months in relation to community engagement. And I know that the comms team and a lot of the stuff has been going on behind the scenes, and there were loads of community meetings. I'm just surprised that hasn't moved a little bit during November until now. A lot of work has gone on. So are we doing ourselves a disservice when it comes? I know there's still a lot of work to do.
Yeah.
But I just wonder if
it will be ongoing, won't it? And the nature of the nature of that engagement will change according to what the communication that we need to have with our communities as well. I take on board what you're saying. Simon and I have spoken about how we can review this going forward, so we'll pick it up.
Yeah, I'm not going to say it should be. I agree. It's almost it should be a different, but I just feel it doesn't just do the work that we're doing service, because I can remember the bad old days when our community engagement was very poor in general terms. It's certainly a totally different dynamic now when you think all the work has gone on, and there's evidence to support all the great work that's going on, and most of our strategies and policies are being involved in the community. It's just a thought from me as your community representative.
No, thanks, Matt. Simon.
I was just going to say, no, we've got a board development session on the 14th on community engagement. So that's probably a good space and a good time to kind of look into that in a bit more detail and see whether or not, we need to look at that.
Yes, and importantly, I think it is worth stating this in public session, that board development session will be held in Cannon Link in Aberdeen in a phenomenal community-based service, and I think that's a good way of setting a standard for future sessions out and about. But no, thank you. Thank you. Yes.
Yeah, thank you. No, I thought it was really a good document around board assurance framework, and really helpful. And I really like the fact that we've got the risks and then we've got the assurances. Just on, obviously I looked at the sort of finance one where we're looking at the changes from 20 to 16. And I suppose I had just had a question around what are controls and what are assurances, because I would be used to seeing internal and external audit as more of an assurance than a control. But it's just a query really, and it's probably too detailed for this sort of meeting. Maybe something that needs to be picked up in assuming Audit and Risk Committee, but yeah, is that all right? Pick it up there perhaps, but just as a point. Yeah, thank you.
Thank you. Okay, any other questions to Gareth on the report? I've just asked colleagues to approve the board assurance framework. Yes, thank you very much. That's approved. Item 6.3, board committee and advisory group highlight reports. That just to say these have been included on the agenda as are matters included in the reports that do require escalation through the board. I'll come to the quality and safety committee highlight report first, and Carolyn's going to lead the update. Thank you, Carolyn.
Thank you. Yeah, I'll take the report as read. Just to note the areas of escalation, as it says, committee members received a presentation on ophthalmology and were provided with assurance about the action taken to that, and did consider that this may be something the whole board would want to receive at a future point. We also noted the board approval for the closure of the maternity and neonatal improvement programme following the de-escalation. I'm very happy to note the de-escalation of Teeth Lydiard. The committee also met again last week. There aren't particularly any issues to escalate from that, but I did just want to highlight that we had two listening and learning stories, one from Donna Walker in the bereavement service and one from Amy Davis, who talked to us about frailty. And I'm sure other members find this, but those presentations actually were hugely impactful in terms of demonstrating what a difference we can make to patients, to families in these services, sometimes for actually very little investment, and led by very committed and positive leaders for those services. So I just wanted to commend both of those reports, and they gave us great assurance about positive changes for the future, but otherwise happy to take any questions on that.
Thanks, Carolyn. Before I throw open questions, Dom?
Yeah, thanks, Karen, for mentioning those two services. I think that they are quite flagship, particularly I took the frailty presentation of how we could do something differently, which is a good example of it. And I think we discussed there, and I think you and I need to catch up outside of here as well. How do we start presenting things that are slightly more this is brilliant what we're doing, but this is great, but these are still the issues that we've got. And I think that's something that we need to move into, that sort of frame and discussion at quality and safety. That's all right.
Yeah,
but,
no, I think that's
your comments on that.
That's a fair comment, Dom, and I think we have had that conversation about we can't just focus on things that are going really well. We need to know where the issues are. But I think in both of those presentations, they did demonstrate the challenges they'd face, and also the challenge of making those things sustainable going forward.
Yeah, thank you, Karen.
Thank you, Carolyn. Any questions to Carolyn on the update report? No. Okay, we'll note the report. Thank you, Carolyn. 6.3.2 Digital and Data Committee report, and again I'll ask Ian to lead on this item.
Yeah, thanks, Chair. Just one item on a positive escalation. It's just that we noted the significant work of the procurement and business case for digital medicines and electronic prescribing in secondary care, and we also noted that this was a leading report in terms of development in Wales. So we congratulated the team on that. So we discussed that earlier in detail, so I'll just mention it there.
No, it's good flagging. It's flag it up in the yes, thank you, Ian. Any questions to Ian? I'm sorry, Suzanne, do you want to come in on this?
Yeah, I just had a couple of points to raise, Mr. Chair. We make reference to the ICO report, and just to give the board assurance that the recruitment is well underway, the resources in support of the in response to the ICO report, and we've been successful in receiving 1.1 million funding for cybersecurity out of a pot of government funding. So we've been able to obviously that will come towards our resilience and our sort of digital plans moving forward. And it was again just to make reference to the board development session that we will be holding in the new year related to digital and data, where our long-term plans will be discussed in full. Thank you.
Thank you very much. Any questions to Suzanne or to Ian? No? Okay, thank you. We'll note the report. Thank you very much indeed. 6.3.3, the Audit and Risk Committee highlight report. I'll ask Sally if we can just a quick update on the report. Thank you.
So I will again take the report as read. There were just two things I think to highlight in the alert escalate. One was around a discussion around JAG accreditation, which we felt was best handled through the Quality Committee, and that has been referred across. But we've received an update on the accreditation process in 6 months. And then in terms of internal audit, there was a general escalation about responses, management responses and target dates, which we've now picked up through ELG.
Thank you, Sally. Any questions to Sally on the audit and risk update report? No. Thank you. We'll move the report. 6.3.4 Planning, Performance and Finance Committee highlight report. I'll hand over to Gethin for this. Thank you.
Thank you, Chair. So the key issue for alert and escalation to board was regarding the financial position and the potential impacts of that, and particularly with the challenges around the cash position. Clearly, that has changed significantly since the last meeting, as Sally's just updated in terms of the finance report. So the majority of that has now moved on, and there are the key issues to escalate.
Thank you, Gethin. Any comments or questions for Gethin? No. Thank you. The board will note the report. Thank you. Item 6.4, working in partnership, the CTM 2030 strategy update. I'll hand over to Linda. Thank you, Linda.
Thank you. I think we've talked about so much of this. I'm going to just try and focus on the very specific element. You'll see that the paper reminds us that CTM 2030 is about building communities and building our community services, as well as the acute clinical services plan. And we are we're essentially at that stage with the acute services plan, where we're building the case for change based on the evidence that the services are providing us at the moment. And the next stages of that are very much, we need to work with our clinicians, and we are doing so across the organisation, as well as keeping the public and other stakeholders sort of informed about the process and keeping everybody aware of what's happening. But, you know, we're not at the stage yet of developing proposals. We're still collecting data and thoughts on that.
Thank you, Linda, for the update. Any questions I'm conscious we've got discussions later in terms of the acute clinical services plan and items such as the Clantrison Health Park. But in terms of Linda's update, any questions or comments? One point just to reflect on it, and you mentioned it already, Linda, but I think it is worth us as we look to plan the shape of our services for the future. Whilst much of the conversation tends to rest on that which we do in our major hospital sites, you know, the Health Minister has made it very clear to health boards that this process is also about, and fundamentally importantly about, what it is that comes out of secondary care and located far more closely to where people live. Because the basis of the NHS in the last 75 years, apart from developing primary care, has been very much around what we do in our major hospital sites. They now do more than they've ever done before. And the question we have to ask ourselves is, what is it we do in our major hospitals that can be better delivered closer to where people are? Lots of people go into hospital for appointments and procedures, which in many cases could be delivered and done so effectively away from the hospital site. And I think that is, you know, that community basis of provision is really important for us as a health board, and bearing in mind the importance that we place on communities, on the engagement with the public, the engagement with community-based organisations, the location of our staff living in our communities. I think that has to be something that we need to keep in the front of our minds as we develop our plans for the future. No.
Yeah, it didn't get a mention here, but it's worth mentioning. But it does support all the work that Linda and the team are doing in relation to this project that we're doing. Is the work that's going on with the building department, assigning now with nobody, but the work up in the Prince Charles Hospital, or the development working with Tilbury Douglas. I mean, the work on community benefits. It really is. I sit on all these meetings with community members, and we've now got a group. I'm not sure. It's probably going to 60, 70 agencies. Partnership work. We're all celebrating all the work that's going on and engaging and supporting all the work that we're doing. And I'm looking at what inspiring people there. Every time I attend those meetings, you see organisations talking to each other, building networks, and at the heart of it all is Prince Charles and Cumtap University Health Board. And it's been driven by a building project, if I can call it that. And I don't know beyond that, but it's very, very impressive.
it's a significant investment in PCH, and it looks very, very different to when it was first built in the.
Well, the community looks different as well. The community looks different because to see organisations that would be invisible now turning up, and they really are talking, engaging, and sharing ideas and supporting everything. And it's from mental health to jobs, it's all working well.
Any other questions or comments to Linda on this particular item? No? Okay, thank you. We'll note the report. 6.4.1, the Regional Partnership Board and Public Service Board monthly report. Linda and I, along with other colleagues, attend a variety of external meetings, one of which being the RPB, which obviously has, as we discussed earlier, an important role because it does spend money in delivering that out of hospital or contributing to that out of hospital care service. Linda, anything to update on this?
Yeah, so I mean, it's a couple of things in sort of governance terms. We do a full report on RPB actions and activities and PSB actually to the PHP. So the Population Health Partnership Committee, and it is noted, and I see in the report, but it's in the consent agenda. And I don't want to repeat myself around, and what you've just said about the RIF fund and the capital money that is being managed in that space. But most of what we talk about there is about the community service model, how we link, integrated community teams to work on a cluster level with our GPs, much more proactively with those, as Paul said earlier, with those patients that we know are at risk of becoming unwell and responding more readily when they are unwell to prevent them going into hospital. There is work going on that model. There's quite a lot of noise. There's the 6 goals work from that Welsh government. There's a further, faster imperative and lots of diagrams. And it strikes me that I think we're pulling it all together. And as Paul said, Matt Jenkins has just started working with us to help steer this. And it strikes me that because it's so important, because the only way we're going to get services out of our hospital is to strengthen our community, right? You've got to do it that way round. So I'm actually thinking that maybe we should factor in board development, full briefing on what's happening in that space so that people have a better understanding. And I think in a couple of months we'll be in a good place to do that. Yeah.
Yes, I welcome that, Linda. Yeah, absolutely. Yeah.
Like with the PSB, I think it's fair to say that we had the wellbeing plan ratified, so that's now live. We are working with partners actively, especially with local authority partners, in terms of how we can start realising the ambitions within the wellbeing plan. And we've got a piece coming up in a minute about the active sustainable travel, for example, and what is there to urgently work together on to deliver for our communities. But as I say, I think the operationalisation really is in development.
There is one specific thing that the PSB has agreed to do, which is to commission an external review of our joint opportunities around decarbonisation, which makes sense as a sort of set of public service bodies, which might help us.
I think just reflecting on some of the concerns of my colleagues in other health boards, the problem with the range of different partnerships that we have. The RPB has a particular role, the PSB has a role. All too often, however, the conversations that I had at one tend to get replicated at the other. And how you maintain momentum and buy-in and enthusiasm, I'm afraid, starts to weaken if people feel they're just replicating the same conversation. So something around decarbonisation for the PSB, I think, is a really useful thing for the Public Service Board to engage in, as opposed to just talking about the sorts of conversations about healthy social care integration, which we chat about in another forum. So yeah, I think that's again, if we can get focus in that way, I think that would be a really good benefit.
And that movement from talking to planning to doing as well.
Yeah. Okay, thanks. Greg, we'll move on to your item 6.5, the Nurse Staffing Levels Act report.
Yeah, thank you, Chair. The paper sets out our compliance position against the NSA section 25B wards, and for new board members, this act only covers our medical wards. our surgical wards and our inpatient paediatric wards. All of our other wards sit outside of the Section 25B Act. So we do the biannual audit. So this is the annual report from the audit we did in January and June. The paper sets out the triangulated method that we use, and we overlay that by ward activity, so how busy the ward is in relation to admissions and discharges, etc. It's important for the board to remember that the establishments initially get signed off and agreed by the ward manager, so they're very much part of the process. Then there's a check and challenge session with the care groups, including the workforce and the financial business partners. Then there's a further session then with the care group nurse directors, and then I have a check and challenge them with them before I sign it off. So there's a robust method of signing off of establishments before they get to the board. Key messages in this report then, just a few. Across our 3 acute sites, over the last year, there's been a reduction in establishments across 5 wards and an increase in 4. And I'm sorry, you should have had the financial information in this cover report at this meeting. I know there was a discussion in the LG, will definitely come to the next board. So a reduction in 5, an increase in 4, largely related to the change of specialties across the wards and how we've increased or decreased bed bases. We're still kind of recovering from COVID. We've had multiple ward changes over the last couple of years. POW still causes me some concern, and I still feel that we're underpowered to some extent with healthcare support worker staff. It's started now to play through in some of our quality metrics. So the nurse sensitive metrics, our pressure ulcers, falls, medication errors, and nurse related complaints. We have started to see a rise in pressure ulcers and POW. We have most patients there that are waiting for onward care, that are deconditioning and therefore getting sicker whilst they're in our care, requiring more one-to-one supervision and observation. And as you can see in the report, we do have less healthcare support workers in POW than the other 2 sites. I think what will help when the catering service starts within POW, so we have 9 wards at the minute where the healthcare support workers spend between 2 and 3 hours dishing out the dinner, supporting feeding, and then washing the pots and pans after. So I think when we have the catering service there, we can reevaluate what the establishment should actually look like. But I'm still a bit anxious about healthcare support worker numbers within POW. Clearly, we do use discretionary staff if we need to. What's been great since I reported the last year, we've now rolled out our safe care module across all of our key sites. That aligns to e-rostering. So what that means, we have real-time visibility of rostering, fill rates, acuity of patients at the press of a button. So I can see all of our sites, all of the rosters, and what the ward managers are writing in relation to their professional judgments. That's really good for staff deployment in the moment when we do struggle with that. I guess finally going forward, the template is mandated as part of the statutory guidance. There's lots of information in here. We can play about with obviously the main report, which we will definitely include financial information. And I'm sorry again, it wasn't in this report. I have been on leave and I didn't sign off, but we will do that. Thank you very much.
Thank you, Greg. Any questions? Lisa?
Thank you, Chair. Thank you, Greg. It gives real insight to the required establishment, but forgive me if I'm missing it. It would be really helpful to have information on how compliant we are.
With the,
I can only see the required establishment, but I can't see whether we met the required establishment.
in terms of the fill rates, you mean?
Yes.
See, and that's a big challenge for us, isn't it? Because, as part of the Act, isn't mandated because there's a challenge in collecting the data in relation to that. Although we have started, we do it manually. So we know 3 times a day through our student meetings what the fill rates are, but to aggregate that up using a digital format is really tricky. No health boards can do that because we don't have the national system to do it. We are compliant in relation to the funded establishments. That's what's mandated by law. Our fill rate generally is 80 to 85% by day, 100% by night. So our rosters are mostly filled by night. By day, it's a lot more tricky in relation to our vacancies and getting agency staff, because agency staff want to work by night as opposed to by day. It would be wonderful if we could have that fill rate, and we are working on that.
Thanks.
Just to support what Greg has said, really agree with everything there. I guess that will evolve over the next little while. We've got some plans there to improve that data, and we've also just recruited a head of data and workforce analytics into my team, a proper analyst. So we've got some capacity there to improve some of the workforce data issues that we've had. So we'll keep you posted as that improves over time. I think you're right. That's a little part of the picture that we struggle with, but that will improve over time.
Thank you both. Any other questions to Greg or to Howard? No. Okay, we are going to take a 5-minute break, just for a brief pause. And I've been dreadfully generous. It's that pre-Christmas spirit kicking in. I use this, yes. So, yeah, so we are pausing.
We're still live.
Okay, ladies and gentlemen, welcome back. We'll now return to item 7 on our agenda, strategic planning. 7.1 is a CTM 2030 clinical services plan. There's a report for the board to note, and I'll hand over to Linda for this item. Thank you, Linda.
Again. I obviously jumped the gun earlier when I referred to the process in this paper around the acute clinical services plan, but so I'm not gonna, I don't think there's anything in here that we haven't said already today, but this is a useful documentation of the state of play at the moment in terms of the activities being undertaken, and you know, a reminder to everybody that this is happening, and you know, it is a coherent plan of activities. I'm happy to take questions.
Any questions to Linda on the report? No? Okay. Linda, thanks. I think the report is comprehensive. I know we're going through a very robust process in developing a clinical services plan. There are lots of discussions going on amongst within the board. Huge conversations taking place with our partners in other statutory bodies, with, of course, members of the Senate and members of Parliament. And of course, very acutely aware that we'll be having very detailed and thoughtful conversations with the public and importantly our staff about the shape of our clinical services for the future, about what we deliver, how we deliver it, how we are aiming to be better at the way we deliver their health services. And of course, I think there are great opportunities here now to think about that model of delivery for the future, which is based on ambition and enthusiasm about what we do. So thank you for all the work you're doing and for the team, not just your team, but the team who work with Simon and of course all our exec colleagues who are leading on this important piece of work. And I know we will return to this at all of our board meetings and of course engaging with board members in between those sessions as well. Can I offer a very warm welcome to Rosie Cavell, who's our programme director for the Llantrisant Health Park. The Llantrisant Health Park, of course, is a crucially important part of that clinical services plan in remodelling and reimagining what it is that we deliver as a health board and how we do it. It is a major plank of our infrastructure programme for the future. And Rosie's been doing a sterling job as our programme director. So, Rosie, over to you. Good to see you.
Thank you. Good afternoon, everyone. So, if we could move on to the next slide, please. I just intend today providing a bit of an update on the progress that we've made to date. I think probably the last major update was back in December 22, just before we were proposing to purchase the site just over the road. I can confirm luckily we have now purchased that. We purchased that in February. So since then there's been a considerable amount of work. So I'm proposing to provide an update on some of the master planning work that we've been doing, an update on the tenancy situation. You may recall that when we purchased it, BA were actually a British Airways, so it's still in occupation and had a lease that runs until March 24. We've also been undertaking some space planning and concept design type work. And I want to also give you a bit of a flavour for the likely programme and timeline for this, and then some plans around interim capacity while some of the major works are ongoing. Move on to the next slide, please. So one of the first pieces of work we've done is we've appointed Arcus, who were involved in some of that original concept planning to provide programme management support to us. We've also got architects and engineers appointed to start to undertake some of the original initial master planning work. The high level plan from December, which still remains, is that Building 1 has still to be fully confirmed at its utilisation, but probably need to provide some overarching support to the site. However, Building 2, we're looking at diagnostics and endoscopy. We're looking at putting theatres, both orthopaedic and day surgeries, into the third building. And at the far end of the site, there is a developable area, which we're planning on creating an inpatient bed unit to support Building 3 with the theatres in. So if we move on to the next slide, probably just makes things a little clearer. Some of you I know have been on a site visit, so this is all familiar. For those of you that aren't, obviously that we know the location of the site is literally just around the corner, directly very close to the Royal Morgan. If we move on to the next slide again, that just gives an overview of where we are proposing to put those services. So at the moment, you'll see on the far left-hand side, we've got the proposed, that would be a proposed modular new build. The other three are based in the existing buildings. So at this moment in time, that hasn't changed. But we are still looking at some of the detail behind that. To move on to the next slide, just to give everyone an overview. As I said before, British Airways remained as tenants, although they were not in occupation of the site when we purchased back in February. The first few months were spent with a fair amount of negotiations and discussions, and the site was handed back to us with an early release from BA from their lease on the 29th of September. There was a payment in association with that release of 1.8 million. £500,000 of that went towards counts as the rental payment for the rest of the year. 1.3 counts as something called dilapidations, which is basically recompense for any maintenance work that they potentially haven't been taken. And that might explain why perhaps there haven't been a lot of major communications around the site in the first few months. These negotiations were quite commercially sensitive. Had BA really grasped the fact that we were planning on ripping out a lot of the internal factors of the building, it would have been very difficult to agree any kind of financial settlement with them. So now that we have control back, we have all the payments, everything is all settled. It does mean that we have unfettered access now to carry out all the necessary surveys, but also that we can sort of speak a little bit more widely about the plans and proposals for the site. So if we move on to the next slide. So just starting to look a little bit now around the buildings and details. So if we were to look at perhaps the community and the diagnostic and endoscopy hub first. Now, this has been taken forward by a regional team, and the whole concept of Welsh Government providing the funding for the site was that this was going to be a regional site. So we need to make sure that our regional partners are fully engaged, and there has been some really productive work both in the regional diagnostic and orthopaedic work streams. So in terms of the diagnostic and endoscopy hub, the teams are looking at the appointment of a commercial partner for this building, and the proposal is that they will develop 2 regional centres across the South East Wales region, with one of those being at LHP. The partner should be identified by March 24. The plan will be that the partner will fit out the cosmetic elements of the building, providing the equipment and some of those basic elements, and they will provide the staff then operationally moving forward on a managed service type basis. However, from our perspective, there are elements that we will need to do to the building, both in terms of statutory compliance and general infrastructure, that we will need to address for them to go in. So it will be a bit of a partnership piece of work. We can start some work initially, but there'll be a lot of work once that partner is there to look at, to confirm building layouts, what we do, our side of the work, and for them then to be able to come in and provide that information. What we are doing whilst that procurement process is ongoing, again, working with our architects, we've got some basic schedules of accommodation working through, looking at how things fit, how things can lay out, and working with some of our internal diagnostics teams on a bit of a sense check. Have we forgotten anything? Does something need to be in there? Does this work? Just making sure we're getting that right, so that when we've got a partner on board, we can hit the ground really running on the actual detail with them. We move on to the next slide. The same sort of work is going on with orthopaedics, and I think there's a little bit more detailed work, especially internally, around how some of the theatres can work. They're big buildings. Each building is over 3,500 square metres. However, there is a lot of space required to support theatres. So we do need to do some detailed work on logically how many theatres we can fit with sensible recovery spaces and everything else around it to make sure that everything flows properly, we don't have bottlenecks, but we can work as efficiently as possible. So we've been looking at two different types of theatre, barn and conventional. And I think some of the team had a really productive visit down some barn theatres in Poole to have a look at how they work in practice. And I think that really helped focus the mind on what we can actually do on this site.
Rosie, it's just worth explaining to those people who don't understand what a park is. Maybe explain what a barn theatre is. Some people might not be at home.
Sometimes I think you get so caught up in working it through, you just assume. Right, traditional theatres generally have one table in one room. So patients come in through an anaesthetic room, you have a single table. In a barn theatre, you have separate airflows, but you have a number of tables in one larger area. Sometimes if you watch sort of American war type films, it's sort of traditional military type layout, but there are amazing efficiencies in terms of how patients can come in and out, how anaesthetists can potentially work across field mixes and supervision. So there are opportunities in how barn theatres work, but to be clear, each table has its own ventilation aspect. And I think that probably panics a few people, but so each table will have its own separate field where its own ventilation through. So infection control is obviously not a risk. So I think there are opportunities, and this would be a very, very different way of working. And I think there are real opportunities to embrace how that can work. And certainly I think the plan is to develop a bit of a partnership with down in Poole, because there are lots of lessons to learn, and I think there are lots of ways of getting different groups of people engaged in how this could work as a model moving forward. Some of the things we do need to think about, though, coming back to the main layouts, is the plateau we have that we can develop for inpatient beds will comfortably fit 2 24-bedded wards. I think there was an ambition to have 236, but we have to be realistic in what we can put on there, because we are limited on that space. So we need to just work through again around some of this capacity planning and working through flows, what that means in terms of number of theatres and recovery space. And we've got a healthcare planner on board who's supporting us with that work. And also a lot of this is being discussed through the regional work stream as well. So we do need to, we have to have that crossover between the academic exercise and the clinical input. And I think that's being balanced very well at the moment. So we move on to the next slide. So one of the other things we've been tasked to do is to look at how we can meet the ministerial ambition to have patients on site by the end of 23-24. I'm sure you will all understand that the works of the main buildings are significant. There is a lot of work to do, which we will get through as quickly as possible. But if we want to see patients on here, we need to think a little bit differently over how we can do that. So what we have been looking at is opportunities around mobile diagnostics, most notably MRI. We can work in partnership with Cardiff, because obviously Cardiff own on behalf of NHS Wales 2 mobile MRs, and one of those can be made available to come to site. So we will look at a short to medium term interim solution where we can start to open up the LHP site, start to have it seen as a point of provision of care in the region, but in a way that is safe and enables us to still keep working in the background on the balance of the site. So we're about to go for planning to have the mobile and a small support unit on there. Obviously patients will need a small wait area and staff will need a little bit of support as well. And we're establishing an operational working group as to how we can actually make that happen. And our target date is to be on there by or before the end of March. It's ambitious, but it is doable. So moving on to the next slide. The programme has been quite a challenge, I think, to everybody. There is a traditional way of working up a capital construction programme, and there are very traditional ways of working around the business case structure and around how partners work. And I think, so having worked on the Grange Clinical Future scheme, knowing that was 5+ years before we got on site from original concept, we know that can't be the sort of timeline that this programme follows. So there are a lot of challenges to all parties, ourselves, some of our partners, Welsh Government, shared services, to see how we can shorten out traditional, quite long time frames. And I think all discussions have been good. If we work to an ambitious traditional programme, it would see us on site probably until summer 2025. That obviously isn't where we want to be. We want to be targeting starting on site on at least one building in 2024. So we are looking at all options that we've got to bring that forward. And to be fair, Welsh Government are working very closely with us. Instead of having the traditional 3 to 4 month business case scrutiny process, we're looking at regular briefings and updates to Infrastructure Investment Board, who oversee all the business case approvals process, so that they are taken along in the journey with us. And hopefully that will keep approvals processes, sign-off processes relatively tight, relatively short. We will be engaging with shared services specialist estates, who again scrutinise all aspects of the business case. We're getting them in from the outset, so they are part of the design. So everything is signed off on the way to the business case, rather than presenting a very meaty document at the end that everyone reads and picks holes in. So I think as well as that, we'll be working with the planning department and all of the stakeholders that we can, looking at how we can challenge previously accepted timelines to really bring this on site as quickly as possible. But it will require a lot of quick decision making, quick turnarounds, and also challenging some of our partners to work slightly more responsibly than they have done historically. So again, it's ambitious, but not impossible.
I think also, Rose, it's fair to say, isn't it, that there's the balance also of wanting to engage as many clinical colleagues as possible in helping shape it, but not allowing that to completely, go into a very long protracted sort of. There are some key strategic decisions like barn theatres or not barn theatres, etc., where we do need to make sure we've got that clinical engagement, because that does really shift the way in which people operate. But there will come a point in time when we have to be a bit like, well, we need to be a bit more sort of directed here, and we've got some support from Glenys, who's a colleague from an Devon Health Board, who's coming to work as part of the project team. She was been very involved in setting up treatment centres in England, and has had quite a lot of learning for how you do this to engage the clinicians and keep them on board, but don't allow that to sort of track the timescale so long that it ends up being years and years before we actually start doing any work on science.
Yep. Yeah, just saying, just come back on that. Partly it's getting the right clinicians who are in that mindset already, who want the changes. Can I just a couple of points, just going back on the subject of the rate. This is just so incredibly exciting. It really, really is. I mean, this is completely different than we've done before. But I just want to add a note of reassurance on the barn theatres, because knowing this is an open forum and people hear, oh, we're going to be treated in a barn, the quality and the safety stays an absolute paramount in all of this. That is not effective. It's about, to use with when you talk about traditional ways of doing the model, it's about tackling the traditional ways that we deliver healthcare, and it's not the same as importing what we do in theatres on the 3 sites and just adopting this practice on there. It has to be a whole new way of thinking and working, but the quality and the safety comes first when ensuring here, and that is the key requirement here. And they've done that at Poole, they've done that on other sites, and it's just, I think unfortunately the term barn theatre can make people panic, but it's not about quality of care. Sorry, I know I leave that point, but it's really important.
That's fine, and certainly if that is the way it's preferred to go forward, then we will be providing that, providing a lot more detail so people can see and understand that concept and on the right basis.
Just in terms of next steps, anything else on that you want to cover off, Rosie?
No, just the next slide. I just wanted to just pick up on how the programme will continue. It's kind of continuing at pace in terms of we're just appointing into now programme team as wider support. Paul's already mentioned influencers come on board. We need to bring a lot more people on board and to make sure that we've got a good strong resource team to commit the time to this, to really keep this moving quickly. We will be looking again with the right level of engagement at developing more detailed designs, moving towards 1 to 200 detailed plans, appointing a construction partner as early as we possibly can, bringing them on board. Again, just trying to overlap each stage a bit to get rid of some of that traditional programme lapse that you've got in moving from one stage to the next. Yes, right. Did you also?
No.
We've got an infrastructure investment board, again, initial review on the 14th of December. The content of that review will probably be very, very similar to what's come to board today, just giving them an overview, just setting up and giving them the assurance of the progress and the steps made. And the next 2 confirm
we're trying to get into planning as quickly as possible with as much as we can to try and stop that sort of being a bit of a block or a delay. So we're working with our colleagues who have been extremely cooperative and extremely helpful in the steps that we can take to keep this moving. So planning will probably be one of our next key steps.
Get him.
Thank you, Rosie. And I guess it's just to in part reiterate the really exciting opportunity this gives us. And it gives us that on a number of levels. The first is about providing a genuine environment for us to have a centre of excellence for our orthopaedic services, but also for our day and diagnostic services, and particularly about how we do that in partnership with our regional partners. So if, in terms of orthopaedics, we're working exceptionally closely with Cardiff and Vale and Anara and Bevan. There's an awful lot of work going on to learn and to have a standardised pathway. Doesn't matter. So wherever you're treated in South Wales, you will follow the same pathway and be evidence-based. And just picking up, Rosie picked up the issue of the size of the wards. We've seen a significant reduction in our length of stay internally within the CTM for orthopaedics. And there's still further opportunity to reduce that. And we've been working with the NHS Nightingale Hospital in Exeter, who now are probably doing 90%, 95% of their patients are treated within, discharged home within 24 hours of their initial surgery. So, when you think about 7 to 10 days as the historic length of stay for joint replacement, it's a massive change in the way we work. The biggest opportunity, I guess, though, with LHP is to really think about that model of care and the workforce that needs to drive it. And the visit that the team went on down to University Hospitals Dorset in Poole. Yes, they saw some brilliant physical environments, but actually what I think one of the most compelling bits that came back from that visit from the team was the culture and how the building develops a different culture within theatres, which is really positive, and how that space has allowed them to have a very different workforce model to support the delivery. And I think gives us real opportunity to think about how we skill mix, how we use our workforce to provide as much capacity as we possibly can, but for treating our patients. So this is such an important and exciting development.
Ian, do you want to come in?
Yes, I'll bring Catherine. Yeah, a bit left field. I've done a project about a year ago, or so ago now, with a consultant anaesthetist in a different health board, and he was using Draeger and anaesthetist anaesthetic machines. To do the project, we needed to monitor it and get data out of the machine using a computer network, but there were no cables in the operating theatre. So we couldn't do the project basically because of that. So to cut a long story short, the reason I'm saying this is now that you're doing a build, can you please put data cables even into the operating theatres, because all the modern machines now are being data connected. So it's important. Now's the time to do it. You can't do it in a sterile environment once you've built it.
In addition to being our exec medical director, of course, Dom is so Dom, it's such interest.
I'll ask this in an anesthetic point. So what we've done now is the new anesthetic machines that we have here are all back up and keep a record of what happens during the case. We need to now link those directly into the patient records. They're automatically printed out, so you don't have to keep a paper copy now of the anesthetic record. So to do that, it's going to have to be linked to be able to work that through, and that's almost part of the electronic patient record going forward. So yeah, it's a basic requirement. It has to be done.
But I think Ian's point is really important, because this is also an opportunity to make sure that we think about how we future-proof these buildings, but also we've got a real opportunity to work with industry partners, because we've already had a number of kit suppliers and other people expressing an interest to be involved, because they see this as a landmark facility and want to be associated with it. So I think absolutely, and we've got to be thinking about all this technology that we need to have embedded from the day one.
Just, I'll come to Catherine and Linda, and I'll come back to Linda and Carol.
Okay, yeah, thank you. Yeah, really, just to echo, really exciting. And I just think there's an opportunity in the next steps to also think about comms and engagement, particularly CTM 2030, because, general public want to know about health services. I know we separated out the clinical and acute services over here, and we've got Manchester Health Park over here. But ultimately, it's all part of improving our healthcare. So it'd be really nice to see as part of next steps how we're going to do comms and engagement. Not asking for it now, but just when we're thinking about and how we bring it all to for the
describe it as part of the whole overall picture.
Absolutely, to help healthcare.
Yeah.
Sorry.
Okay, if it's on the comms bit.
Just quickly, there was an unsuccessful recruitment process for a regional engagement and comms manager who's going to help support the comms on this, particularly so they'll be working across the whole region, so with us and AB and Cardiff and Vale. That was unsuccessful. We're going to go out to that again, but there is absolutely a really good story to tell here, a really positive hook around which to build our stories about change, because change doesn't necessarily have to come with, it doesn't necessarily have to be bad. It doesn't necessarily have to be something that people need to start getting concerned about. It also brings with it some really positive changes as well. And if we talk about what we're doing at HP, we can then talk about how other services need to kind of change around that as well to fit in with that new model.
Okay. Of course, Linda is one of our independent members, is sitting on the LHP programme board, which has been incredibly helpful.
Just very quickly, I suppose we've had lots and lots of meetings. I want to say well done to Rosie because it's not easy. Well done to Paul because it feels like at every meeting you're basically going, how long? Can we cut it? And I suppose just to reassure everybody, when we all went around and had a look at it, we got super excited about it, and then nothing happened because you're doing all the foundational work and everything. It feels like the next few months are going to be really, really important. So maybe come back maybe after, in the summer and talk about what's happened. But I suppose it's worth flagging. This is not without risk, this programme, in terms of we have to resource it properly. Rosie's got to get a proper team, got to get those timings sorted. So there's a lot to be done, but, obviously it's super exciting for the future.
Linda and then Philip.
Mine was on digital as well. It's that this isn't just a chance to get our clinicians to think differently about how they operate. It's about how we do the whole end-to-end pathway and how we automate as much as possible and use this as a stepping stone to how we redesign our services generally.
And likewise for me, it's not just about the clinical staff as well. I mean, we're talking about expanding diagnostics and the opportunity for health scientists. And I mean, clearly this will be an attractant for recruitment as well. I mean, it's a massive benefit to. But that expanding of diagnostic capacity, the potential for reference laboratory potentially, and in conjunction with the universities, developing that sort of regional hub of innovation, of science and development, etc., which leads to high quality, ongoing employment, etc. I think it's a massive boost to the region, not just to the university health companies. So
so I suppose what's really encouraging is a lot of my points about kind of workforce have been said, which is really good because this is a building project, but it's also much more than that. It's a workforce transformation project as much as anything else, and there are huge opportunities there, not just for those who end up working within the facility, but more broadly. And I also think you can't ignore the step up in ambition, optimism that something like this delivers for our organisation, population and the region. So there's massive opportunity in this. I'm desperately keen to start getting into the workforce aspects of it once we're clearer on what we're going to be doing in the model. But I think, there's huge benefits.
Thank you, Hal. Okay, any other questions to Rosie on the program? Rosie, thank you. I know this is a huge piece of work, lots to get done, reliant on other partners as well doing their bit, but I'm really pleased to hear that you're engaging them right at the outset so that they're involved in the design and the consideration of all of this and not just having to deal with responding to things as and when the work is done. So I'm acutely aware that the public sector in particular in Wales is very bad at delivering projects too tight, and the pressure is on us to deliver this. I accept that other people very often have a very definitive view about how processes need to be applied. My view is we should always look for a workaround on some of these things. COVID showed us we could work differently and more smartly and more creatively, and I think we ought to recapture some of that spirit of innovation. So I know you're on this, and it's reassuring. So a lot of work to be done, and thank you for what you're doing.
Helpfully, the ministry is also very keen to get
absolutely
quickly, so she's also helpfully from her side, pushing into the process from government. So that's helped. Yeah.
Thanks, Rosie. Thank you very much indeed.
Thank you.
Item 7.3, the active travel charter.
Thank you. Thanks very much. And I will assume that people have read the paper, and I will rattle through this at quite a length. So can I get the next slide, please, Times? This has already gone to the Population Health and Partnerships Committee. And I mean, we're aware of the sort of wider wicked issues that we're facing in terms of declining physical activity, increasing obesity, diabetes, air pollution, worsening health inequalities, as well as climate change, which is affecting all of us. And much of this comes down to how we not only travel in terms of cars and vans, etc., but also in terms of how we plan our environments. And we're going to need to have bold action. This links to the point we were talking earlier in terms of how we work across public sector organisations within the PSB. Next slide, please, Tyler. So, as you can see, I mean, this is just some background. This is how we travel. So since the 1960s, there's been a steep increase in people using cars, vans, and taxis. And I appreciate that there is a move now over to electric vehicles, but that is just part of the solution, and in many ways offsets an issue that we have. Next slide, please. So, this is what it looks like in our communities. So, if you look back in terms of Conti, over the last 50 years, this is more than 50 years, this is about 100 years, but in any case, our built environment have been dictated by cars, not necessarily by people, right? And that impacts how kids can play out on the street in a very basic sense. So, next slide, please. So the impacts of how we travel, it has impacts directly in terms of physical activity, road traffic injuries, we've got a statistic in a minute, but also loneliness and social isolation, people getting in their cars individually, going off to where they need to go to, coming back again. And it's had a huge impact in terms of green spaces, climate change, and those health inequalities, which obviously for public health are particularly stark. Next slide, please. And these are some of the statistics. So if we look at the injuries and fatalities caused by road traffic accidents, it especially affects children, and it especially affects children in deprived areas, right? And so this is an inequality issue. We can obviously link it to diabetes in terms of sedentary lifestyles, and also the wider ramifications of air pollution that are really only just coming out now in terms of the research, in terms of fatality, and also in terms of low birth weights, etc. Next slide, please. So what we need to do, and this is long term, and it can't just be the health board. As I say, it's a whole society approach. But we need to redesign how we build our communities and how we commute and how we travel between them. And that will be not only about individual travel, but also public transport as well, and ensuring transport links can enable people to come to health appointments, for example. Allowing communities to connect that are often cut through with major roads, protecting and enhancing our green space, and all of that will have an impact in terms of air pollution and carbon emissions. And what's needed is for us collectively to provide leadership. Next slide, please. So who needs to act? Click, 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 click. There you go. Brilliant, thank you. So I mean, this is a whole of society approach, really. And what I would say is that these healthy, active, sustainable, whatever your particular in on this is, they exist, have been tried elsewhere and are being implemented elsewhere. And in fact, Pentath Morgana is something of an outlier in not having the healthy travel charter. Next slide, please. So it's an opportunity for public services to sign up to commitments. And nationally, this is being led by a consultant called Tom Porter, who works at Cardiff and Vale Health Board, and he's been working with health boards across Wales. These exist in England as well. But as I say, CTM is somewhat late to the party. And it's an opportunity to improve active travel opportunities, not only for the public, but also for staff as well. Staff need to get to places, and we know that physical inactivity is an issue with our staff, leading to sickness and absence, etc. It is about signing up a commitment across organisations, which are then co-produced. This isn't a one-size-fits-all issue. Clearly, the context in Cardiff is very different to North Bridgend, for example. I would switch this round. Actually, it's ambitious, but it is achievable because it is being done elsewhere. Next slide, please. So, to date in Wales, I'm not going to go through them, but there have been numerous signatories to this, and just in terms of organisations and businesses, this may be in terms of working with transport organisations to ensure that public transport can get to sites, or building bike shelters, shower blocks, etc., to enable people to commute in actively. Next slide, please. So the proposed next steps, we would like to take this to the PSB for there to be agreement on this. It's already within the wellbeing plan, and so this will be supporting the wider ambitions of the public sector partners. And then there is a range of activities looking to actually operationalise this, really. And I had some challenge within the Population Health and Partnerships Committee.
Save me from asking it again.
No, so what's the evidence that this works, right? And what is the how do we change these sort of lofty aspirations into actions? And so I can share afterwards some of the case studies that have been done in Cardiff. What I would say, they implemented their charter in 2019, and obviously COVID-19 impacted on that quite heavily. But what they have seen, you actually saw an increase well, a decrease in public transport use during COVID for obvious reasons, really. But that then decreased and has risen, but has not reached the levels it had before. So it is having an impact in Cardiff. And clearly Cardiff is a different context, right? It's very different travelling around in a major city to travelling here. But this is one of those things where we have to do something, really, because the option of doing nothing isn't really available to us. We need to change the way in which we operate. So next slide, please. So specific matters for consideration. We're asking the board to confirm their commitment to the whole system approach to healthy weight, which you already have, by supporting the development of an active travel charter within Cwmtaf Morgannwg. We would like to take this to the PSB. We're already working with the officers from the Public Service Board on this, so they're very keen. We would ideally like an IM to champion the active travel charter, and I'll speak to people separately after this on that. And we would like the health board to become a signatory of this charter. As I say, numerous other health boards have signed up to similar. So that's the end of it. Thank you.
So, I mean, absolutely, I think we need to sign up to it. I think what we just need to think through, and that's a conversation with Howard and your colleagues as well, around the workforce, because one of the challenges we will get back, I can hear already, will be, well, I would cycle to work, but there aren't changing facilities, or there's not showers, or there's not. So we probably need to preempt that before we go out to speak to everybody, because it will be one of those things. The other thing I was just thinking is, Linda, it ties in with the conversation we're having on that wider basis around transport across the patch, whether you're a patient or a member of staff, actually, because actually one of the biggest barriers to healthcare at the moment is transport, and it comes up time and time again when we talk to communities about issues with access. And many of our staff would have the same challenges. Absolutely. So there is something for us. If we're thinking about developing a different approach to transport, then it shouldn't just be about our patients. It could also be for our staff, and the opportunity for us to think about different options for bus services at a time when the public sector funded bus services are being reduced dramatically. We need to think about maybe we, in partnership with the local authorities and other members of the PSB, fire, police and others, may want to think about creating our own transport offer for our staff, because actually if we could provide alternatives that are electric minibuses driving around all our sites, there's a viable, at the moment I don't feel we've got a viable alternative to offer to our staff, because we don't have, as you said, we're not in a city centre, there isn't lots and lots of public transport available. So I think we're just going to think about what we when we present this to our staff, that we also put alongside it the plan of what we're going to try and do to improve some of the infrastructure ourselves. recognising that that all comes with a cost. And they've got to shed loads of capital money. So just, I'm not saying we shouldn't do it, but we've got to go into it with our eyes
to be
open.
pragmatic as well, and because there are various flavours of support to this, ranging from people who say every journey should be taken by foot or by bike, and who think that electric cars are a wolf in sheep's clothing, through to Transport for Wales, for example, who are very keen in this for commercial as well as for the wider industry.
Ian, Delissa.
Yeah, I agree with everything in this, but I'm confused as well because I don't quite know what you mean by an active travel plan. Are you asking us that we develop one?
No.
No, or because what I'm confused with is if it seems to me reading the detail of it, we talk about cycle tracks. Is that what we're talking about?
No,
I'm very confused by it.
No. So this is very much a whole public sector and private sector organisations have signed up to it as well. So it won't just be cycle tracks, as I say. It will link into the public transport infrastructure. We've got the metro that's developing, but we do have brilliant infrastructure in terms of we've got a cycle lane that runs right from the hospital to the train station, for example. And how do we support people to use that infrastructure? Okay. But in terms of the plan specifically, this isn't something that the health board can do on its own. It's something that is very much a regional multi-organisation approach.
But the public, as has been said, will have kickback against this because they'll say we live in the Rhondda or we live in my state, and I'm not taking a bike to it because I go up a hill like that to get back. It's just things like that.
And likewise, this isn't about we are going to ban cars overnight.
No,
this is a pragmatic approach.
I view the sympathies.
Yeah, there will be a lot of people who will be very pleased to see a lot more cycling lanes in the area. The other thing I think we need to think about is not just the staff, it's about the visitors and everything. Perhaps we need to think about how we allow visiting within our family members just been in hospital, and his wife was catching the bus to the hospital to visit, so didn't visit in the evenings because it was difficult getting home. So perhaps it's about looking at more flexible visiting hours, etc., to link in with what we're doing with the active travel plan.
And just it's exactly on that though. I mean, if we think about the Maesberg redevelopment, we're already working with transport organisations, aren't we? And so this isn't just about new things. This is about highlighting good work that's already ongoing.
Thanks. No. Yeah, there was a film once called A Field of Dreams, and the strap were like, build it and they will come. I'm picking up on this because there's a huge issue, lots of huge issues at the that we all want. It's like, let's all not drink, let's all stop taking drugs. And
Thank you, you're doing my job for me.
Yeah, I'm with the film, and I'll send to anything that will encourage people to do the right thing.
Absolutely.
However, I'm a realist by nature, and I know I'm picking up against point and all the points that have been made here, right? Because it's easy, it won't be so much the hill that will stop people going on their bikes and sending kids up on their bikes. It's public safety and security, because we live in an environment now, and like the Southwales Police, Paulie mentioned police, I've got to buy into this big time as well, if it's going to happen. Because if you go and have loads and loads of people saying, right, we'll let our kids walk to school, we take them out to school, then there are lots of people out there who are not very friendly people who will see this as an inducement. What an opportunity. So there's lots of stuff. And there's sometimes those stuff outweigh the issues of it. Let's everybody getting on a bike and getting fitter. That public safety issue is such a compelling argument and affair in communities now that I just think it overrides everything when it comes to, if you had families here, that would be the number one concern. I know that, everybody else can take the bikes. I'm making sure my child gets to school okay, and I'm going to be there with my car waiting, because it's a choice. So idealistic as it might be, I think there are so many other issues that we've got to consider. But that doesn't stop me saying I'm more than happy to sign up for the charter, because I want things to get right. But the realist is, I think there's huge problems, other problems as well as going to impact.
It's a prisoner's dilemma, right? In terms of, in order to keep your kids safe, people buying bigger and bigger cars, and they can. I mean, most of us walked to school, didn't we? Really. But you're absolutely right. This is, and that's why it needs to be a multi-organisational.
Absolutely.
I was just thinking about what you're asking us to do here. I think you're asking us to sign up to an active travel charter, which I think we're hearing that everybody wants to do. And just thinking about it, because Carolyn and I obviously sit on the Public Health Committee, Carolyn chairs that, and if you want to come in, Carolyn, on this, but we had a very robust debate about all of this. But I think really realistically, right, this is going to be an incremental campaign. We are not suggesting that within a 12-month period, everyone's going to be on their bikes or doing anything. So I suppose I'm looking at it from a big picture perspective and thinking I'm trying not to go down a rabbit hole with any of the individual things, but just thinking this is a step in the right direction. But we still need to see a plan for some of the things that within the health laws give before we even get out to other organisations.
Really, this is we're seeking permission to take this to the UHB to say we collectively will develop a plan that is custom made for CTM.
I think if anything, I accept the point about, improvement is incremental. It's a step by step. We're not going to change things overnight. But what this is about, to my mind, is sending a signal about our ambition. That actually, go back to health points. We want people to be healthier and more active, and to support, encourage, to help people to do that. And there are a couple of ways of doing it. I mean, you can either inspire people by investing lots of public money in new cycle tracks, in new bus routes, in new railway stations, and the whole metro thing now has been developed by Transport for Wales. Or you can attempt to force people into public transport, which isn't always an encouraging and enjoyable experience, by making the use of their car more miserable. Now, as a resident of Cardiff, I can tell you the way they've done it in Cardiff is to make driving around the city more of a miserable experience. That's the way that they've in part attempted to achieve that transfer of people out of car and onto public transport. But public transport isn't always an enjoyable experience, right? And Paul's right. If you look at where the bus subsidies have been cut, we've lost bus routes in Wales in the last 12 to 18 months. But notwithstanding the fact that there are challenges in doing it, it ought to be an ambition for a health board to want its staff and its population, as we've set out in our CTM 2030 strategy, to be healthier and travel to the place of work or to visit somebody in a hospital, whatever it may be. I think is absolutely fundamental point.
Just referring back to the LHP discussion we've just had, we've got a great opportunity with the side to think about this sort of approach to how do we make that, because it's important, that would be important that's on the bus route, that we have to be bringing it to by public transport. So it's just an example of how we need to just embed this thinking and this approach in all of our planning.
And Merthyr Council are in communication with the public health team. They're redeveloping a school on the Gurnos, and they want to know how do we make it healthy by design, part of which will be how do we walk to school, how do we cycle to school, etc.
Okay, Philip's slide asks us to make those commitments. I would suggest the board that we are happy to do so. But of course, there's a lot of planning and development work that needs to take place, and perhaps to learn from other parts of the UK or even in other parts of Europe where they're more advanced in achieving this. And these things are doable, but it just takes the effort and the ambition to do it. So Philip, thank you very much indeed. Okay, just moving on to item 8 before we conclude. Item 8.1.1 down to 8.1.6 those items for approval on the consent agenda. Can I just take it that colleagues are happy to approve those items on the consent agenda? 8.2.1 down to 8.2.5 those items for noting by the board. Item 9, there's one other item of business, and Carolyn wants to briefly report back on the CTM research conference that took place last week, which I had the pleasure of attending as well. It was absolutely first class. Carolyn, I'll hand over to you.
Thank you. Yes, very briefly, just to say, as Jonathan said, the conference was held last week. I just wanted to highlight to the board that it was an excellent conference, really good range of speakers and presentations. I've asked for the posters to be put together as a PDF so we can send them around for you to see, because it's very difficult for me to get across to you the range of work that was showcased there, which speaks to all of the issues we've discussed today, doing things differently, checking the value of what we're doing, standardising processes, encouraging people into research. And I thought it would be useful to look at those posters, but also for us to think perhaps at a development meeting about how we bring that more into all of these conversations that we're having, because everything we've spoken about today speaks to needing to think differently, and research and innovation is clearly part of that. But I was absolutely blown away by the range of work happening there, and I just wanted to congratulate John Geen and Rhian Bainion on putting that together, because it showcased CTM in a really positive light. It was a great conference. Thank you.
Thank you, Karen, and I would certainly endorse the need to make board members aware of the range of work that's going on. And I was amazed at the size of the event and the range of different research across the organisation in different parts of the organisation. That, of course, is all about improving patient care, the patient experience, and giving staff the tools to do the job more effectively than they are doing now. And I just think it was absolutely first class to see the range of work on display. Item 9.2, how we did in the meeting. Just remind colleagues that any comments or improvement for our board meetings, if you can come back to me within the next 2 weeks in respect of the issues we've covered and the way in which the meeting has run. Item 10, just to reaffirm, as we're in public session, we did have an in-committee board meeting first thing this morning, and the following items were discussed: the clinical services plan, the case for change, the digital medicines business case, and the quarterly update on capital. Just to confirm, the next meeting of the public board is Thursday, the 25th of January 2024 at 10 a.m. But in the meantime, there will be a board development session on the 14th of December at Cunninglink in Aberdare. I'm very grateful to our colleagues there for being able to accommodate us for that board development session. Rwy'n dod y cyfarfod y bodd iechyd ben, a hofyn y ddiolch y fawr sydd wedi ymuno yn ni y gwylio'r cyfarfod heddiw. And I'll bring the board meeting to a close. I'd like to extend thanks to all those who participated in the meeting and those who have observed the meeting today. Thank you all very much indeed. Thank you.